Good morning. I'd like to call this public hearing of the Committee on Health to order. Today is Wednesday, October 9th, 2024. The time is 9:32 a.m. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. We are in room 500 of the John A. Wilson Building. This is a hybrid hearing with witnesses testifying virtually and in person, and then we'll have our government witnesses testifying in person. Today, we will consider two bills under the committee's purview. Bill 25-948, the Certificate of Need Improvement Act of 2024, and Bill 25-0690, the Public School Health Services Amendment Act of 2024. Excuse me. We have public witnesses for both measures. So I am actually going to split how I describe each bill just so it's fresh for everyone of what we're talking about. So first, the Certificate of Need legislation. I introduced Bill 25-948, the Certificate of Need Improvement Amendment Act of 2024, along with Council members Allen, Bonds, Lewis, George, and Parker on September 16th, 2024. In my role as chair of the Committee on Health, I make a point of visiting hospitals, primary care clinics, ambulatory surgical centers, and other facilities that make up the district's healthcare system. Consistently, the providers I speak with bring up the Certificate of Need process, or CON, as a challenge to their operations, and sometimes a barrier to their ability to provide critical health services to district residents. When a health facility wants to open a new location, expand its services, or make a major capital expenditure, or even shut down services, it must apply for a Certificate of Need, or CON, showing the public need for the project from the State Health Planning and Development Agency, SHPDA, within DC Health. Although 35 states require CONs of some type, the district requirements are the third most extensive among U.S. states, covering 25 types of healthcare services. Receiving a CON in the district usually takes about 6 to 9 months and can incur significant associated expenses. Although the CON process can be cumbersome, it is a critical tool for the district, allowing us to increase the pool of providers that accept Medicaid and encourage health providers to be more equitably distributed across the city. This bill aims to strike a balance between maintaining the benefits of the CON process and removing unnecessary burdensome obstacles for health institutions and providers. Specifically, the bill proposes the following improvements to the district's CON process. It exempts virtual provider networks and virtual telehealth platforms from the CON process and instead requires DC Health to create a registration process for these entities. It exempts office-based primary care and specialty practices, which would align the district with other states and encourage more primary and specialty care services to locate within the district. It requires biennial updates to the capital expenditure thresholds to accurately reflect economic changes. It excludes non-patient care capital projects from the CON, such as installing a new elevator or garage improvements or even HVAC upgrades. It removes the 3-year limit for CON-approved capital projects and proposes a more flexible approach to extended timeline if the applicant is making good faith efforts to meet the schedule. It clarifies the definition of a group practice, since group practices are generally exempt from the CON process, and it adjusts the number of licensed beds that must be modified to trigger a CON from 10% to 20% in order to avoid small facilities going through a very lengthy CON process for small changes to their operations. In developing this legislation, our committee conferred with health providers, institution, advocates in an agency, but we know there are many perspectives we have yet to hear. So we look forward to a robust conversation today about how we can improve this legislation and make the CON process work better and meet our shared goals of health equity and increased healthcare access for district residents. I would now welcome my council colleagues in attendance to make any opening statements they have on this bill. If they could keep their opening statements to 5 minutes, and then we'll get to our public witnesses. I first saw Councilmember Zachary Parker, who's a member of this committee, and he's a council member from Ward 5. Councilmember Parker.
Good morning. Councilmember Henderson, are you able to hear me?
Yes, we are.
Okay, great. Good morning. I am excited for today's hearing because I think it reflects progress and an opportunity for us to provide more supports for our schools. I was proud to join you in co-introducing the Public School Health Services Amendment Act, which seeks to accomplish several things. Many of them you've already touched on. It would establish a baseline of nursing coverage for our schools. It would establish a deadline for schools to request from DC Health nursing coverage. It would also prompt DC Health to provide technical assistance for schools that are not officially in the health school services program, and it would prompt DC Health to collect and share data on how schools are implementing the program. Obviously, this bill is a step in the right direction, but it doesn't quite get us where we need to be. And I just want to elevate some of the things that I know have been talked about in the past, as well as I anticipate we will hear more today. We want all of our schools and students to have nurses. The reality is that DC, like many places around the country, is facing a nursing shortage. And DC Health has implemented the cluster model, which I imagine we're going to hear from some that is working well, and we're going to hear from others that is not working as well. This legislation seeks to establish a baseline while acknowledging there are challenges that the district and DC Health continues to face given our pipeline issues. This legislation also reacts and responds to testimony we heard from oversight hearings earlier this year, namely that there was a challenge posed to DC Health given the late or delayed request for nursing coverage made by schools. And so all that together, what I hope people will take away from today's hearing is that this bill is not the end all, but it is a step in the right direction as we continue to face a nursing shortage, but it is also responsive to direct feedback and criticism that we've heard from partners, schools-based personnel, and DC Health. I'm grateful for DC Health's ongoing partnership. I'm grateful for your leadership on this committee. And I think together we will continue making sure that all of our students are in schools that have full-time nursing coverage. So with that, I'm going to turn it back over. Looking forward to today's hearing. I will be in and out, but really excited for the list of folks testifying today. Thank you.
Thank you, Councilmember Parker. Councilmember Nadeau?
Thank you so much, Madam Chair. I'm just going to say brief remarks about both bills today, just to knock that out for you. I'm eager to discuss the public's...
Councilmember Nadeau, is it possible that you could speak a bit louder?
Oh, sure. Is that any better?
Okay. You are very faint. Can you move closer to your microphone?
I might look a little silly, but I sure can. Is that any better?
Not really.
So it sounds like in the Zoom, it's like audio. The audio is fine. I wonder if it's a room issue.
No, the folks here said it's not us. We were able to hear Councilmember Parker just fine. So, but why don't you go ahead and we'll just lean in on our side.
Okay,
there we go. I don't know what you just did, but you're good.
Okay, is that good?
Yes.
It's weirdly loud now.
Yes.
Okay, great. Well, thank you so much. And I'm very eager to discuss the Public School Health Administration, this whole Public Health Services Amendment Act of 2024. And I want to thank Councilmember Parker for introducing the legislation. Like many of my colleagues here, I'm concerned by reports we continue to hear about gaps in nursing care at schools. Nurses are critical for schools and students, provide regular and even life-saving medical care, and also important for building relationships and trust with kids. As a mom of 2 young kiddos, I actually interact regularly with our school nurse, whether it's for bumps and bruises, illness, or even the assurance that someone will be there if my child accidentally consumes one of her life-threatening allergens at school. Parents want to know that there's a trusted medical professional at school each day to help if something happens, and every parent in the district deserves that as well. DC Health adopted the cluster nursing model last year to address continued staffing issues that plague schools and healthcare practices across the district, but we're still hearing about gaps in care. And it's critical we continue to discuss what's led to the underlying staffing crisis that caused the need for the cluster model in the first place, and how we can better support nurses to keep them on staff and recruit new providers. School nurses deserve living wages, reasonable workloads, and the opportunity to connect with students, and I'm eager to figure out a way that we can provide that. In the meantime, we have an opportunity here to make quicker improvements to our current system, and I'm interested in learning how and how far this legislation will take us in closing gaps in care. I'm also glad we'll discuss the Certificate of Need Improvement Amendment Act of today in today's hearing. In the district, the Certificate of Need process is critical to ensure that residents across the city have equal access to healthcare, but it's important that we examine this process to make sure it's not discouraging the opening of new practices, especially in the case of telehealth platforms that provide innovative options for care. Thank you, Madam Chair. I truly appreciate your leadership in this hearing.
Thank you so much, Councilmember Nadeau. All right, so we're going to move to our public witnesses. The witnesses testifying representing an organization will have 5 minutes to testify, and those representing an individual will have 3 minutes to testify. You're welcome to submit longer testimony, written testimony for the record. Again, I want to remind people, it's not because we don't want to hear what you have to say, but we do want to provide time to hear what everyone has to say on this particular on these particular bills. So if you're please be conscientious of your time. There's a timer here. If you're testifying via the Zoom, there's a timer if you're in grid view. And then I'll nudge you when your time expires. So I'm gonna call the first panel of witnesses, which are in person. We have 4. Jamie Kavanaugh, who's the Legal Policy Counsel for Pacific Legal Foundation. Alcidair Whitney, who's the Legislative Counsel for Institute for Justice. Jacqueline Bowens, who's the President and CEO of the DC Hospital Association. And Anita Bhutani. Hi. Who as the founder and principal of Bright Day Pediatric Therapy. Okay. Ms. Kavanaugh, when you're ready.
Thank you. Good morning, Councilmember Henderson and members of the committee. My name is Jamie Kavanaugh. I'm Legal Policy Counsel at Pacific Legal Foundation, a national public interest nonprofit law firm. We represent Americans in lawsuits to advance equity, opportunity, and to protect private property rights. So over the last few years, I've had the opportunity to become a national expert on certificate of need laws. I've published several surveys of laws around the country and written more in-depth reports, one for Kentucky, for instance, with a PhD economist, where we reviewed every academic study of certificate of need laws. There are hundreds, and those studies have over 400 tests within them, because often one study will ask multiple questions. Because we go to these hearings often and we hear, well, the research on certificate of need is mixed. And we wanted to see if that was true. And it turns out that 89% of the academic tests of certificate of need show a negative or neutral result resulting from certificate of need laws. They decrease access to healthcare, they increase costs of healthcare, and they decrease quality of healthcare. And you'd mentioned in your opening remarks that the district is interested in ensuring health equity. And out of all the tests, there's 17 tests that look at whether or not certificate of need benefits underserved populations. 0 of those tests found any benefit for underserved populations. And some of them found that a disparity between access for Black and white communities. This was a test in New Jersey. They found that disparity in access went away when New Jersey repealed certificate of need for a specific cardiac procedure. I'd also like to mention that the federal government agrees that certificate of need laws harm patients and decrease access to healthcare. Since 1986, every presidential administration has had agencies that call on states to repeal certificate of need laws. This includes HHS, FTC, the Antitrust Division of DOJ, Department of Treasury, and the Department of Labor. And in my written comments that I submitted already, there are specific citations for every single administration. So this is something that both sides of the aisle agree on and work to see states repealing these laws. I'd also like to mention that in my written comments, I have a list of 12 recent reforms from all around the country. There's some very big ones like South Carolina, Montana, Oklahoma. They repealed all of their certificate of need laws except for nursing homes. And this brings the number of people around the country up to about 40% of the population that lives in a state with either 1 or 0 certificate of need laws. And the 1 is usually just for nursing homes. And remember that every state had a certificate of need law at one point in time. So these states that have repealed the laws have all gone through the process of, repealing the laws, whether it's slowly over time or all at once. And we've seen large benefits for the patients in those states after repeal. So Pacific Legal Foundation supports this measure and is very happy that the council is working on this and that you introduced this measure. And I wanted to point out that on the list of the 12 states that have made reforms over the past few years, 9 out of those 12 have included changes for psychiatric facilities and services and substance use treatment facilities, because of course the need for those services is so dire all around the country. And it also creates bottlenecks for emergency departments when patients need to be transferred to access psychiatric care and can't get that, and then take up space in ERs for days or weeks or months. And so Pacific Legal Foundation is also suggesting that the bill be amended to include a repeal of CON for these psychiatric services and beds and substance use treatment facilities and beds, because this is in line with what the majority of states all around the country have been doing. And it's based on the research. For instance, repeal has led to increased access in Florida. Florida repealed its psychiatric bed con in 2019, but it didn't become effective until 2021. And since that time, in those few years, the psychiatric beds in Florida grew from 4,475 to 6,777. So we could see, Florida was able to see immediate increase in access for patients all around the state. And I hope to continue the conversation individually with any council members that have questions. And I also direct you to my written comments. Thank you very much.
Thank you. Mr. Whitney.
Thank you so much for the opportunity to testify before you this morning on this very important piece of legislation. My name is Alistair Whitney, and I am a legislative counsel at the Institute for Justice and a former colleague of Ms. Kavanaugh's. Institute for Justice has worked around the country, both in courthouses and state houses, to help folks understand why certificate of need laws need reform. And I am here today to testify in support of this important piece of legislation, and also to applaud you, Chair Henderson, for bringing this important bill. So we strongly encourage the committee to support this, and for a few reasons. One, ditto what Ms. Kavanaugh said. Telehealth services, primary and specialty care services are DC stands alone in or among very few other states in requiring a certificate of need for these services. And of course, the predictable result of limiting the amount of supply for these services when the district's population continues to grow, and the demand continues to grow, is that it raises costs and it eliminates options for patient care, and it drives some of these disparities that we've been seeing in the district and in other states with certificate of need laws. One thing I'd like to emphasize is that this is reform of certificate of need is a nonpartisan issue. As Ms. Kavanaugh noted, every state, including the federal government, used to have certificate of need laws on the books. Today, several states, approximately a dozen, have reformed their certificate of need laws and no longer have them on the books. And that includes California, Texas, and Pennsylvania. 3 of the largest states in the country, and 3 states that perhaps could not be any more different politically from one another. So you have Republicans, Democrats, independents looking at this issue and saying that it doesn't work for them, it doesn't work for their state. Also, as Ms. Kavanaugh noted, while we think this bill is great and we would happily and do support it as is, we think that there are some opportunities for further reform, and that's particularly with mental health and psychiatric care facilities. especially after a wake of a devastating pandemic, a twin pandemic, not only of COVID-19, but of loneliness and of mental health struggles and of substance abuse. We think this is a ripe opportunity to reevaluate whether certificate of need works for mental health care facilities and services. Americans are in desperate need of these services and these facilities. It is hard if you are somebody in need to get that. And we think that this bill presents an interesting opportunity, or a good opportunity rather, to push for more meaningful reform. With that being said, I again would like to reaffirm that the Institute for Justice strongly supports this bill as is. And I look forward to continuing this conversation with you, and thank you for your leadership, Chair Henderson.
Thank you. All right, Ms. Bowens.
Good morning, Chairperson Henderson and members of the committee. I'm Jacqueline Bowens, and I'm the President and CEO of the DC Hospital Association. And I want to thank you for this opportunity to testify on the Certificate of Need Improvement Act of 2024. I would say that I'm here, I serve on the State Health Coordinating Committee, but I am here representing the DC Hospital Association. DC and its members support the Certificate of Need program, particularly its ability to level the playing field for all providers serving in the District of Columbia. The program ensures access to sustainable healthcare services for all residents, regardless of geography and ability to pay. We commend Ms. Thompson and the agency for their recent efforts to streamline the review and approval process, along with the implementation of new automation tools. The association welcomes the review and ongoing modernization of the CON program to meet the evolving needs of the healthcare providers and the patients we serve. This bill represents a very positive step toward aligning the program with contemporary healthcare practices, and we support many of its provisions while offering a few additional recommendations. We endorse the automatic increase in capital expenditure thresholds to better reflect the rising construction and equipment costs. We recommend completely removing capital thresholds for hospitals, allowing SHPTA to focus on new service proposals and reducing regulatory barriers for renovations. Then this change would have no fiscal impact as hospitals fund CON reviews through a per admission fee. We also support the removal of the 3-year limitation for CON projects, as this flexibility is essential for multi-year projects, as you've described, Chairperson Henderson. The elimination of CON requirements for non-patient care proposals is crucial, whether it's elevator replacements or HVAC upgrades. Timely replacement of these projects is essential for hospital operations and should not be subject to a CON review if they do not expand services. We also suggest expanding the definition of non-patient care expenditures in the legislation to include electronic medical records. We also believe that replacing existing equipment should be exempt from CON review. Currently, equipment that did not initially require a CON because it did not meet threshold requirements will trigger CON review when the cost for replacements exceeds thresholds. As health systems consolidate multiple practices into a single entity to promote operational efficiency, we propose that these consolidations should be exempt from CON review since the primary ownership remains unchanged. Lastly, we recommend expanding the definition of uncompensated care to include community investments. Healthcare expansion has positively impacted DC residents, resulting in a reduction of the uncompensated care hospitals provide. Recognizing community initiatives such as addressing social determinants of health, community building activities, and health equity strategies as part of our 3% uncompensated care requirement would have a significant impact on efforts to promote health equity and improved outcomes. Our members are continuing to assess additional components of the bill, such as the provisions related to telehealth, and we do plan to submit additional comments for the record. And again, as always, I thank you for this opportunity to testify and look forward to answering any questions.
Thank you. Ms. Butani. Oh, hold on one second. Ms. Bowens, if you could turn your mic off. There we go. All right.
Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. My name is Anita Butani, and I am the founder and principal of Bright Day Pediatric Therapy, a forthcoming clinic serving children with autism spectrum disorder and other developmental delays. Our first location will be in Ward 3. I am grateful to Councilmember Henderson and the co-sponsors of this bill for incorporating the concerns of small to mid-sized healthcare practices like mine into this legislation. I'm specifically testifying in support of the language which clarifies the types of healthcare practices which would be exempt from the CON process going forward. The proposed clarifications remove a major impediment to healthcare practices and therefore healthcare access across the district and bring the regulations more in line with the modern practice of medicine and healthcare. Under the current regulations, virtually any health professional or physician's practice wishing to open an office in the District of Columbia must get a certificate of need. For example, under the current regs, a neighborhood physical therapy office that employs therapists, assistants, and a receptionist must go through the 6 to 9 month process to get a certificate of need prior to even signing a lease. A basic primary care doctor's office employing a nurse practitioner, a tech, and a scheduler must get a certificate of need. And SHIBDA, reserving the right to determine if there is a community need for a particular doctor's office, regularly rejects CON applications. This means that a business who signs a lease or purchases a property before going through the CON process is very much at risk on their investment and should refrain from build out until the CON is issued, further delaying the opening of these further delaying the opening of the clinic for those intrepid enough to attempt the process. So imagine getting ready to hang out your shingle as a young doctor, ready to serve patients in your community, and you find a great space that you can afford, only to be told that you'll have to go through an 8-month-long regulatory process to prove that there's a need for your services in the location you've managed to find. For a hospital, this may not be a big deal, but very few entrepreneurs have the resources to be able to sustain themselves through this process or the leverage to negotiate an out with a landlord. For small businesses like mine, which is resident-owned, woman-owned, and minority-owned, getting a CON is daunting and expensive. It dumps a bucket of cold water on folks like me hoping to serve the DC community. As others have testified, DC is the only jurisdiction in the region that requires a certificate of need for this level of healthcare practice, which makes us deeply uncompetitive within the region as a destination to start a healthcare-related business. Hence, many private practices choose to operate in Virginia or Maryland to avoid the hassle of DC. And the residents of DC are the ones who suffer. For example, mothers of autistic children who have to take 2 to 3 hours off of work multiple times a week to get their children to their various appointments in Virginia and Maryland. The kids suffer too, having to sit in the car for those treks, missing out on school and critical social and emotional learning. Thinking about caregivers taking time off of work to travel around the region for care, it is very clear that healthcare access is also an economic issue. So I want to talk about that. First, taxes. Small to mid-sized healthcare practices generate taxable revenues and fill office space, which improves property tax revenues, all to the benefit of the district, particularly in this very difficult budgetary season. And related, although telehealth has its place, healthcare practices by and large remain an in-person business and a high volume one at that. The presence of a single healthcare practice can have huge spillover benefits to neighborhoods in DC. Let's take a business like mine, for example. Once fully staffed, we will see about 100 children per day, and each child will be accompanied by a parent or other caregiver. That's 200 people visiting our block every day. That's 200 sets of eyes on the street deterring crime, 200 potentially hungry or thirsty visitors to our neighborhood deli and coffee shops, and 200 potential bus riders every single day. And that's off of a single clinic using a modest amount of space. Imagine the potential impact if it were easier for more healthcare practices like mine to open around the district, not just in terms of healthcare access, but also in terms of our economy and our vitality. Let me conclude there. And I'm happy to take any questions. Thank you so much for the opportunity to speak.
Thank you all. Ashley, if you put us on 5-minute, just so I can practice good behaviors. Okay. I want to thank all of you for testifying today and providing this great insight. Ms. Kavanaugh, I wanted to ask, because you are an expert here in terms of the CON process, And you've done a lot of research around the economic impact of CON. And you know, you talked a little bit in your testimony about the studies that were showing like negative impact, if you will. What about its impact on access for Medicaid beneficiaries or its impact on uncompensated care?
Thank you for the question, Chair Henderson. So there is a lot of data on this, and I think we'll actually hear from an economist on the virtual testimony as well. So he might be able to speak to this, but I can tell you there is data that shows that states with certificate of need laws pay more in Medicaid for certain procedures, billing codes. People have studied that and found that the costs there are increased as well. And in every measure of cost that's been studied, whether it's cost per patient in a state or jurisdiction, whether it's cost per procedure, whether it's overall healthcare spending, there are lots of tests that find that certificate of need laws don't accomplish what they set out to accomplish, which was lowering costs. And then about underserved populations and access, there are 17 tests that looked at if certificate of need laws increase access for underserved populations, and none of them found any positive correlation. They found that hospitals in states without certificate of need laws often are, hospitals in underserved areas often had higher profit margins in states without certificate of need laws. They didn't find any difference in the amount of charity care that hospitals provide in states with certificate of need laws versus states without certificate of need laws. So the certificate of need laws aren't what boosts charity care.
That's interesting because I think a lot of the proponents of CON talk about, well, we need the ability for uncompensated care. We need to ensure that everyone has parity in terms of access. And so this is a joy of data and research where you get to see whether or not that's actually working. One other thing I wanted to ask about that we're kind of seeing a lot now in the health space with around consolidations. So and not, you know, two primary care independent clinics deciding to come together, but VCs purchasing a bunch of smaller businesses, or, well, I don't know, Amazon buying One Medical, right? Like those types of things. Have we seen any impact on an increasing number of transfers of ownership or consolidations as a result of the lack of, in states where they don't have CON?
I don't have any data on that. I don't believe so. What I have seen from looking at how this process plays out in states is that certificate of need laws increase consolidation because it gives a few centralized providers, big healthcare systems, the opportunity to go through the system, navigate the system. They have in-house counsel. Smaller practices trying to start can't afford the time and expense of going through this process. And so it actually leads to more consolidation because there are no, it concentrates the facilities within big systems, and then it doesn't give new and innovative providers the opportunity to enter the market.
Okay. Mr. Whitney, I want to bring you into this conversation with Ms. Kavanaugh as well. You know, one of the things that when I first became chair of the Committee on Health and sort of hearing about like how long it takes to go through the CON process, I'm like, are we outliers? Is 6 to 9 months like typical in other places too? Or are we doing something, like, are we asking for too much? Are we doing something wrong, or is this normal? That in jurisdictions where they have CON laws, that it can take like 9 months to get through the process?
It varies. Thank you for the question, by the way. I believe it varies widely. Of course, 6 to 9 months is a very long time, and it is important to bring up too, with particular respect to the district, is that this might have a chilling effect on providers coming in from Maryland or Virginia who anticipate having to go through this very long process, right? And then spend a lot of money to see the process through, only to have incumbent providers come in and say, we don't need this new facility in this area. That is a feature of certificate of need laws, and it is a feature of them all around the country. I believe, though, Ms. Kavanaugh, it's 6 to 9 months is maybe in the middle of the pack, because there are varying states that have both, substantive review, for example, has, Kentucky has both a substantive review and a non-substantive review process. The non-substantive review process takes quite a bit less time. The substantive review process, I believe, takes years, can take years. So, yes. So, and that happens in other states as well. So it varies widely is the answer. And it has a tremendous chilling effect on new market entrants wanting to come in.
Yeah, we were talking about this a little bit yesterday and sort of prep for it. And to be honest, when you just sort of think about it on its face, like say you got, and Ms. Bowens, you obviously know this from the hospitals, right? If a hospital wants to purchase a new MRI machine, you have to go through CON process. Okay, so months to get a new machine. The idea being that we don't want too many of these machines out there, but at the same time, if you don't have enough, the one provider who does have it can charge whatever they want because they have a monopoly on the system. It's just kind of I could see where the good intention was, but in terms of like actually playing out in practice, I also see the issues there. I'm gonna go over, sorry, Ashley, I do have some more questions. I do want to mention, so I did hear the two recommendations around removing the CON process for SUD and psychiatric inpatient. So big news, although I don't know if it was really announced, we just happened upon it in our knowledge of it. But in August, SHPTA made the decision not to require CON for residential SUD facilities in the district. So that's only part of what we talked about. And so I think we can have an interesting conversation with them around whether or not we should go further, especially considering this committee has a hearing on October 28th about inpatient psychiatric facilities and why we don't have enough in the district. And frankly, I think some of this conversation might get to that, but okay. Ms. Bowens, I needed to ask a clarifying question around something in your testimony. You said expand non-patient expenditures to include electronic health records or EHR systems. Is EHR considered a capital expenditure for the purposes of CON?
Yes. With respect to the cost, I mean, what happens is if there's any cost, where we get into trouble is around thresholds.
Okay.
And so that's really the issues when you get into issue. And I know that there have been some discussions around exclusions, but we certainly would have to amend the legislation to make sure that that was specific there. Because right now there's a review process and then there's a trigger with respect to capital expenditures, which should be, it's basically the capital expenditures pricing. That's
Okay.
what gets us into trouble.
Okay, we're happy to follow up just to make sure we get some clarification there, because obviously to go through a CON to update your electronic health record, which we want everyone to do. Yeah, the elevator part, I was like, oh, your mic's not on.
I'm sorry. To the director's credit, she certainly is looking at those areas and has a focus on trying to be, so I think there's consistency and support on the part of the agency to get this done. So we feel much better about this than say we did a year ago. So we're making progress.
Hey, it's coming. And I would say, Ms. Butani, I appreciate you testifying and sort of bringing in a perspective of someone who is seeking to start a practice here in the district and hearing a little bit about your experience is definitely illuminating, right? When we talk about especially on the pediatric side, but this on pediatric specialty care, when folks talk about the months it takes to even get an appointment because we don't have enough providers. I think this is part of this issue that's kind of hidden. In many cases for folks who don't necessarily know the nitty gritty of the healthcare system space, they would name 5 other things that, why folks aren't choosing the district, whether it be high cost of rent and this, that, and the third, which are all things that are part of it. But the CON process, I don't think an average lay person would say like, oh, that's a problem. And that's a thing there. But so I thank you for bringing this up and bending my ear on this, and also for everyone who sort of brought this issue to our attention, for being patient with us as we work through the process. I know that the mayor wanted to start this conversation through the budget process, but we felt like it needed its own discussion. And so I appreciate you all being here. And I think this rich discussion only illuminates why we needed it more. Yes, Ms. Bowens.
Thank you, Chairperson Henderson. I would say that one of the things that we also want to keep in mind, and I appreciate hearing from everyone, and as I said, the hospitals support CON, but we also support very much the reforms. And we do think it's important that as we think about opening up space and looking at those reforms, that we do keep in mind the importance of an important piece of what the law does. It does make sure that there is a focus on access and that providers are looking at providing access to everyone, regardless of ability to pay. And what we do want to avoid is that when new entrants do come in, that they don't focus in only in locating in locations where there are not as many underserved patients. So I think that's a value of this program. And it is something that we want to make sure that when folks come to work in the city, and that when people show up, that they all have access to the same amount and levels of care. So I just wanted to go on the record with that piece.
Great, thank you. All right, so we're gonna go to our.
Councilmember Henderson, could I also just respond to that regarding the location? So many folks think that Ward 3 is not a location where you need care. And if you look at SHPDA regulations and what's required for CON, they really require you to demonstrate need in the District of Columbia. And the reality is that DC is a region. Residents of the district go to Virginia for care, and residents of Virginia and Maryland come to DC. And as sort of the center hub of the region, we should be trying to attract more providers around the city because the demand really is there. I would also say that with regard to Medicaid, our practice, page 1, accepts Medicaid and will accept Medicaid always. That is not a factor in the CON process. It doesn't exempt you from having to get a CON. So if you think about it, those of us smaller providers who make the decision to accept Medicaid and then on top of that have to go through this 8-month process, it certainly doesn't do anything to enhance the number of providers that accept Medicaid.
Great, thank you. All right, so we're going to turn to our virtual witnesses. For those who haven't done a hearing with us before, you have to affirmatively accept our invitation to become a panelist. Margaret Durkin from TechNet, Doc Winston from the Medical Society of DC, Matthew Mitchell, and Tom Mann from ATA Action. And so we'll have those folks testify. Is there anybody else who wanted to speak on this bill? All right, everybody's here for the next one. Okay. So we'll give it a minute while these folks come in to the room. All right, I see Margaret. So why don't you go ahead?
Good morning, Chairperson Henderson and members of the committee. My name is Margaret Durkin, and I serve as the Mid-Atlantic Executive Director for TechNet, a technology trade association. Thank you for the opportunity to speak today on B25, 0948, the Certificate of Need Improvement Act of 2024. TechNet supports this bill as telehealth is a vital component to the patient care model, and we support any initiative that will ensure access and also expand existing access to residents in the District of Columbia. While we do support the bill, we did want to offer one suggestion related to the registration requirements outlined in your proposal. We believe that they may be duplicative and arbitrary, as a lot of most medical groups and doctors already have to register with their respective licensing boards and also register at the Office of Tax and Revenue. Again, thank you for your leadership on this important issue. We did support the measure last year when the council was discussing this issue, and happy to support it again and take any questions.
Thank you so much. Doc Winston.
Good morning, Chair Henderson. My name is Doc Winston. I am the president-elect of the Medical Society of DC, and I'm a practicing urologist in Washington, DC. The Medical Society of the District of Columbia is the largest medical organization representing Washington physicians in the district. We advocate on behalf of all 11,000 plus licensed physicians in the district and seek to make the district the nation's model for patient care and physician practice. We appreciate the opportunity to testify today on behalf of the society in favor of B25-0948, the Certificate of Need Improvement Amendment Act. First, we want to thank the committee for holding a hearing on this issue, and for council members Henderson, Lewis, George, Bonds, Allen, and Parker for introducing the bill. We also want to commend DC Health and Director Terry Thompson's office for engaging with the medical society on this issue, even in areas where we have disagreed. The society has been concerned with the interpretation of the statute governing certificate of need and its impact on the DC medical practices. MSDC has heard instances of independent practices receiving certificate of need inquiries for basic changes, such as replacing a physician or even altering an exam room, which is well beyond the usual scope of a certificate of need. While the district has a robust, vibrant, and innovative healthcare system, our small geography means that the district needs to be constantly ensured that its statutes and regulations are competitive with Maryland and Virginia. Asking practices to hire an attorney and spend thousands of dollars to see if they need to undergo the certificate of need process makes it easier to decide to relocate incoming practices to a few miles over our surrounding borders. In particular, we want to highlight the bill's definitions, which exempt practices from certain sizes and patient care types from the certificate of need process. Equating building a new hospital with redoing a waiting room is preposterous, and exempting smaller practices allows them to innovate and improve patient care without having to worry about unneeded paperwork and expense. Thank you for the opportunity to testify today.
Thank you, Dr. Winston. Mr. Mitchell?
Good morning. Thank you all for having me here. My name is Matthew Mitchell. I'm a economist and a senior research fellow at the Knee Regulatory Research Center at West Virginia. I've been studying certificate of need laws for about a decade, and I recently published a comprehensive review of the literature in the Southern Economic Journal, and I thought I might share some of what we've learned about these laws with you today. So, standard economic theory says that if you have a supply restriction, I'll tax your memories back to Econ 101, it's going to shift the supply curve back and to the left. And this tends to increase prices, reduce access, and undermine quality. That's the theory, but we don't have to rely on the theory alone. We can actually look outside our windows, gather data on the real world of experience of Americans. And as it turns out, about 4 in 10 Americans live in a state with either no or limited certificate of need law. And we can compare their experiences controlling for all sorts of other possibly confounding factors, the economy, demographics, things like that, to see what happens. And so the overwhelming evidence is that the data on con law support exactly what economic theory would predict. Con laws seem to be associated with the evidence is 4 to 1 against the regulation in terms of its effect on higher spending, like less access and diminished quality of care. The evidence is especially strong when it comes to spending per service. It's 9 to 1 against con. So all these arguments that we need con to restrain spending, it just doesn't stack up against the data. On the availability of services, it's especially strong. It's 11 to 1 against con. So what do we mean by that? Well, it means that patients that are restrained by con laws have access to about 30 to 48% fewer hospitals per capita, 30% fewer rural hospitals, less relevant in DC, but 13% fewer ambulatory surgery centers, 25% fewer open heart surgery programs, fewer psychiatric services, fewer dialysis clinics. Patients drive longer for care. In terms of quality, this means higher mortality rates for heart attack, heart failure, and pneumonia, higher mortality following natural death, septicemia, diabetes, chronic lower respiratory disease, influenza, lower nursing staff ratios, greater use of physical force in nursing homes. And then the evidence, I finally see my time's in the red, but the evidence is especially lopsided, I'd note, in terms of vulnerable and underserved populations. So con seems to be standing in the way not only of care for average patients, but especially for minorities, those in rural communities, those who are facing particularly difficult circumstances. So that's the balance of my time. I see is up, but thank you so much. I appreciate the opportunity to chat with you today.
Thank you, Mr. Mitchell. Mr. Mann?
Good morning. My name is Tom Mann. I'm here representing ATA Action, the advocacy arm of the American Telemedicine Association. I'll keep my comments brief as we've submitted written testimony already for the record. ATA Action supports this legislation as a good clarification of the Certificate of Need law, which was enacted well before the widespread adoption of telehealth as a common method of treating patients. This act ensures the law will stick to its original purpose for regulating capital-intensive healthcare facilities located in the district. Indeed, of the 35 states with similar Certificate of Need laws, ATA Action is unaware of any that require telehealth providers to obtain such a certificate prior to offering services in that state. However, ATA Action respectfully asks the committee to amend this legislation to remove the Department of Health registration requirement for telehealth entities. ATA Action believes the registration requirement would be redundant as businesses operating in the district are typically already required to get a business license and register with the Office of Tax and Revenue. Furthermore, practitioners delivering services using telehealth platforms must be licensed or registered with the appropriate district professional board before they can provide services to residents located in the district. Again, on behalf of ATA Action and the telehealth community, thank you for the opportunity to comment in favor of this legislation, and we're happy to make ourselves available as a resource for this and any other telehealth matters before the committee. Thanks again.
Thank you, Mr. Mann. And thank you so much to this group of witnesses. I just want to mention, for the record, we've been joined by Chairman Phil Mendelson. And he's been listening to the conversation. I might have some questions after I am done. I want to follow up with Mr. Mann and Ms. Durkin. You both said similar things around the DC Health registration process. I think, Mr. Mann, you said it would be redundant, and I think, Ms. Durkin, you might have implied that it would be overly burdensome to the telehealth community. While I recognize that telehealth providers would need to be licensed in the district, if they don't individually work for themselves, so let's say you work for a practice group or a company or an organization, and there is a particular complaint that's lodged here in the district with regard to that one provider, who do we go to if we don't know what entity you're working for? Right? Like, our licensing board can certainly take action against your license, but it would be, I think, improper for us not to also alert your employer to the complaint as well.
I don't have a specific answer on that. I was going to say, which you mentioned, alerting the board, but I can ask some of our members and potentially get back to you on that.
Okay, I think that we get to sort of follow up on, because again, right, I'm trying to, I hear the telehealth company, so I'm trying to think in terms of the least restrictive. Obviously, having a company that is not brick and mortar going through the CON process, I totally understand that argument. But, I also have an agency who also talks to me ad nauseum in terms of consumer health and public health safety and the need to be able to have information should complaints arise, which they do, not just about telehealth, but any sort of licensed professional, essentially to make sure that we're not passing around our lemons if there's a particular issue. So if you could follow up with the committee on that, that would be really great. Dr. Winston, thanks so much for you being here, for testifying, and congratulations as president-elect. I have a really good working relationship with the other presidents of the Medical Society on a variety of different things. I wanted to ask a clarifying question. You mentioned in your testimony that some of your members have had the CON required in terms of altering the exam room or changing physician. Can you say more about that?
I don't have the exact specifics these are just the feedback that we've gotten for our membership, where expanding their practices to accommodate increasing patient panels that they've been tasked with having to register a certificate of need for this expanding their practices within their current walls, or even just buying a office next door. I'm happy to get those specifics if it's necessary.
Okay, all right. Well, that's helpful. Thank you so much again for being here. Mr. Mitchell, I wanted to ask you something I talked to Mr. Whitney and Ms. Kavanaugh about earlier around some of the research that you've sort of seen, particularly around Medicaid access and uncompensated care. And I should give you a minute to sort of speak to that.
Yeah, thank you so much. Yeah, it's a great question. So if it would help, I wonder if I might take a second to state the argument that con advocates sometimes make about why it would increase uncompensated care.
Okay.
Because just from a simple perspective, you might say, well, why would a supply restriction increase supply? And the basic idea here is that there are certain procedures that providers offer that are really more remunerative than others. And so sometimes people argue that, well, a safety net hospital, for example, has to treat, emergency care, and they're going to lose money on that. But they can make that up if they can charge higher prices for knee replacements or hip replacements or something like that. And so what I kind of want to point out is that this is sort of a really roundabout way of doing this, right? We're saying that we're worried about Peter, who's underinsured or uninsured, not getting enough care. So we're going to give Paul a monopoly in the hopes that he charges Mary a higher rate and then somehow manages to offer more uncompensated care back to Peter. It's a very sort of Rube Goldberg complicated way of doing it. And, I guess it's plausible that it works, but I don't find it particularly surprising that the evidence suggests it doesn't. So in terms of the specific test of uncompensated care, there've been a couple of studies on this. The most recent was one by Thomas Stratman in the Southern Economic Journal that finds no increase in uncompensated care in states that have con laws relative to states that don't. We also find safety net hospitals, hospitals that serve, communities that are lower income. They actually have lower profit margins in con states relative to non-con states. There's no evidence of this sort of cream skimming where new entrants take the most remunerative care away from others. And then in terms of the specific question of Medicaid, this has been studied a bit as well. And the evidence is most of the evidence is inconclusive that there's sort of no effect of con on Medicaid reimbursement. But of the tests that do find an effect, it's actually not a good one. It's that Medicaid spending is higher in states with con laws relative to states without them.
Okay. That was very helpful. Thank you so much. Let me turn to my colleagues. Councilmember Nadeau, do you have any questions for this panel of witnesses?
I don't, thank you.
Councilmember? Okay. Chairman Mendelson, do you have any questions?
I do not have questions for this bill,
Okay.
but thank you, and thank you to the witnesses.
All right. Thank you so much to this panel of witnesses. I just want to say, so that's the last of the public witnesses that we have for that. Ms. Thompson is going to come after we finish with the public witnesses for the next bill. But I did want to say for anyone who is listening specifically about the certificate of need legislation, the record will remain open until 5 p.m. on October 23rd to submit written testimony. So if you want to submit written testimony, or for anyone who is testifying today who didn't submit your written testimony, please go to the council's hearing management system, which is on our dccouncil.gov website, and just upload your testimony so we can make sure that we have that for the record. Thank you all to this panel of witnesses for a very robust conversation, and I look forward to talking more about this with Ms. Thompson in a minute. But we're going to turn now to the public witnesses for the Public School Health Services Amendment Act of 2024. Bill 25-0690, the Public School Health Services Amendment Act, was introduced on February 2nd, 2024 by Councilmember Zachary Parker and myself. The bill seeks to address several of the challenges within school health suite staffing raised to the committee, including at a January 2024 roundtable on this issue. Specifically, the bill would require that a registered nurse be assigned to every DC public school and public charter school for a minimum of 30 hours per week during the school year. and summer school. Those schools that participate in in the school health services program cluster model, which includes RNs, LPNs, and health techs working in the cluster schools, would meet these requirements. I will note that at least at the beginning of this school year, DC Health reported that there were 40-hour-a-week coverage at every school, which is well above the 30-hour requirement for this bill. This bill would also establish an October 31st deadline for schools to request nursing services from DC Health for the following school year. DC Health had previously testified before the committee that requests for staffing late in the school year caused fiscal and operational challenges for the following school year. Finally, the bill would require DC Health to provide technical assistance to schools not participating in the school health services program and annually collect and publish data on school nursing services coverage. I'm going to turn to Chairman Mendelson to see if he has an opening statement because Councilmember Nadeau already gave hers.
I do not have an opening statement. This bill was sequentially referred, so it will be coming to the committee of the whole after the Committee on Health, assuming the Committee on Health marks it up, which is my interest in the bill.
All right, thank you so much. So we'll call our in-person witnesses first. I have 4 seats. Willem Dickey, who's a coach teacher at Amadon Bowen. Maria Blauer for Advocates for Justice and Education. Can you see Maria? Okay. Neela Wright. All right. Ayan Sheikh. Ashley Simpson Baird from Brea Public Charter School. Okay. Capri Romney and Brady Woodhouse. All right. Were there any of you guys who are also hoping to testify in person on this bill? Yeah, just here. Okay, I just want to make sure. All right, great. Mr. Dickey, when you're ready. Oh, you got to hit the button. Yep, there you go. Nope.
Yep.
There you go.
I'm Willem Dika, and I coach first and second grade soccer for DC Scores at Amadon Bowen Elementary School in Ward 6. I'm speaking on my own behalf today, not that of DC Scores. I came before this committee twice this past January to highlight the new nurse cluster model's failures, particularly when it comes to the availability of a nurse for aftercare programs such as soccer and increased access to administration of medication or AOM training. At that time, Amadon's longstanding full-time nurse had been replaced by a less qualified medical technician who was only at the school 2 or 3 days a week. My concern was specifically for my players with asthma, since sports can facilitate an asthma attack. This is no longer a hypothetical situation for me. As a videographer, I filmed our DC Scores upper grades final game of the season last May, and while I didn't know it at the time, when I checked the footage of one of my stationary cameras, one of our players had collapsed late in the game, apparently because of an asthma attack. A child suddenly collapsing on the field is traumatic and was mitigated only by the fact that he had recovered by the end of the game. The availability of medical staff aside, since games often run late and this incident happened after 5:30 p.m., the presence of someone who is AOM certified can not only avoid a tragedy, but in an emergency situation such as this one, AOM certification would shield coaches who may need to administer asthma inhalers or EpiPens during an emergency from civil liability, as I've learned from the 2022 DC Nurse of the Year. I also hope that you will ask Ms. Robin Diggs-Purdue of DC Health, who is testifying today, why she and DC Health abruptly reversed course on this issue. During the questioning of the January 4th roundtable hearing, Ms. Purdue and Children's National CEO, Dr. Nathaniel Baer, stated that they would open up AOM training to coaches who wanted to be certified. But then, in a follow-up hearing on January 22nd, when you, Chairperson Henderson, asked them about this issue, Ms. Purdue stated that AOM training was the responsibility of third-party vendors and separate from the school health services program. DC scores, it does not even have a first aid requirement, let alone one for AOM. I've included a link to highlights of these exchanges in my written testimony. And so as coach for a third-party provider, I still cannot receive the DCPS AOM training, and organizations such as the American Heart Association will not provide this to non-health professional individuals. This past September, the State Board of Education passed a resolution that would reestablish what every student, parent, guardian, and school staff want: a full-time nurse by the 2028 school year at every DCPS public and charter school. From testifying at an SBOE hearing last July, I learned that the SBOE has the power to introduce legislation into the council by passing such a resolution, which it did unanimously. And my understanding is that the Universal Full-Time Public School Nurse Requirement Amendment Act of 2024 will officially be introduced into the council next week. The current legislation before this committee, the Public School Health Services Amendment Act of 2024, is merely a codification of the nurse cluster model that is unsustainable. Its promise of 30 hours of full-time nurse coverage for every DCPS public and charter school, which would only guarantee that a nurse would oversee a school and not actually be physically present, is not attainable even if the legislation were enacted, since according to the SBOE, only 44 school nurses remain for 80,000 DCPS students that comprise 117 public and 63 charter schools. And that 44 number is down from 82 nurses just 1 year ago. Nurses are leaving not just because of salary, but many fear that their licenses will be in jeopardy since they cannot be expected to responsibly handle the oversight duties they are being given. You will hear more on this resolution today from its author, Mr. Eric Boulay, the former Health Committee Director, who along with SBOE representatives, staff, and also some incredible high school students who are also testifying, made this resolution happen. I urge you to listen to their stories. Representative Parker, as co-sponsor to the Public School Health Service Amendment Act, you stated on January 4th that you supported full-time nurses for all students. And Chairman Mendelson, you stated at our ANC 6D meeting this past January that you thought that you and your colleagues on the council supported a return to the full-time model. But this committee seems to believe that the statement made in the January 4th hearing by DCPS's Dr. Bennett, that prior to the implementation of the cluster model at the beginning of the 2023 school year, there was, in her words, an all or nothing situation under which 60% of DCPS schools had a full-time nurse and the remaining 40% had no health coverage. I urge you to look at the 2022-2023 school health program document that I have included with my written testimony, which shows that nearly all of the 40% of schools without full-time coverage at least had part-time nurses present. Currently, the nurse cluster model cannot even reach full-time coverage for 60% of schools with less qualified medical techs. Thank you for your.
Thank you.
Yeah.
Ashley.
Good morning, Chairperson Henderson, Chairperson Mendelson, and council staff. My name is Ashley Simpson-Baird, and I lead research and policy work for Berea Public Charter School. As you know, Berea is a unique two-generation school that provides education not only to children, but also to their parents, offering early childhood programs, adult education, and workforce development all in one comprehensive model. At Berea, we are in full agreement with the spirit of the Public Health Services Amendment Act of 2024. We deeply understand the intrinsic connection between health and education. In fact, this belief is at the heart of Berea's more than 3-decade-long partnership with Mary Center, a federally qualified health center. Through this collaboration, we have developed what we call the social change model, where we meet the needs of DC families holistically by integrating education, medical, and social services. This partnership ensures that families receive not only high-quality education, but also comprehensive, culturally responsive healthcare and social support services. Berea shares 3 facilities with Mary Center, whose services go far beyond what can be offered by school-based health professionals. Through our shared referral system, Berea families can quickly access physical, mental, and dental health care, ensuring that their needs are addressed in a timely and comprehensive manner. This partnership allows us to support the well-being of families in a way that is holistic and responsive. Moreover, Mary Center offers culturally and linguistically sensitive care. Their providers speak many of the home languages of our families, most of whom are immigrants, which fosters trust and ensures that families are fully understood and supported in their healthcare journeys. This depth of service would be difficult to replicate through a traditional school-based nursing model. For schools like Brea, which have this level of integrated care through partnerships with federally qualified health centers, the requirement to provide additional school-based nursing coverage creates an unnecessary duplication of services. Therefore, I urge the council to include an exemption in the Public Health Services Amendment Act for schools that are co-located with health clinics. Thank you for your time and consideration of this important request. I look forward to continuing to work together to ensure all DC students and families have access to education and healthcare that they need.
Thank you. Capri?
Hi, everyone. My name is Capri Romney, and I'm a senior at Washington Latin High School and the co-founder and president of the Health Justice Club. The Health Justice Club is a student-run interscholastic organization representing the voices of students who are systemically disadvantaged and underserved by DC's nursing cluster system. I am here today to advocate for the State Board of Education's bill that will be introduced later this year and the strong benefits it will have on students like me. To summarize my story, which I'm sure some of you guys have heard before because I've been doing this recently, I had an experience that happened in February of last year where I had collapsed at my school and there wasn't a nurse to be found. And that was when I was diagnosed with POTS, postural orthostatic tachycardia syndrome. This experience is one of many that has underscored the importance of having a professional healthcare available at my school. Managing POTS requires regular breaks and access to high sodium snacks, resources that should be provided by a school nurse. However, due to the lack of consistent nursing staff, I often find myself without the necessary support. This is dangerous for the student, and it places an unfair burden on the teachers who are not trained healthcare professionals. And we need a plan to get nurses in schools, and this act is that plan. The 2024 Public School Health Services Amendment Act is a first step, but the SBOE's resolved bill calls for nurses to have more than 30 hours a week. And you mentioned that we had 40, but that's not what the students are actually seeing. Nobody should need to worry about basic health needs when at school. This act prioritizes young people and their education by realizing students can't reach their full educational potential if easily treated health issues are holding them back. I should be worrying about my math test later today, not my sodium levels in class. Many students depend on school nurses as their primary source of healthcare, so ensuring a nurse is always available at school provides essential care that some students might not otherwise receive. Empowering our community to collectively support every child's health needs. This act also prioritizes the nurses by giving them a retention plan that will help them help us. Supporting full-time nurses in schools is a crucial step towards ensuring the well-being and success of our young people. Thank you for your time and consideration.
Thank you. Brady?
Hello, all. My name is Brady Woodhouse, and I am the president of the Health Justice Club. Our club, as Capri introduced, is an interscholastic student advocacy initiative. We've worked over the past year to bring the School Nursing Shortage Center to our policymakers' agenda. And our club includes students with chronic illnesses, sustained injuries, and just regular students who have fallen to the margins of DC school nursing care. I speak for the rest of the club when I express my excitement and support for the School Health Services bill that the SBOE will introduce later this year. Since my diagnosis with type 1 diabetes 5 years ago, my experience with school nursing support has been a shattered version of the service DC Health promised me. There are some weeks where I have low blood sugar events 3 times because school makes my blood sugar volatile. Although the system forces me to manage on my own, if diabetes were ever to make me pass out, I can't administer glucagon. In that case, who will? The new resolution seeks to amend the problem sprouted from the nursing cluster system. For example, 30 or 35 hours of medical support a week is the standard, yet students continuously find themselves disadvantaged by a nurse's absence and by a health technician's lack of full nursing capabilities. On another note, 30 to 35 hours of medical support a week isn't enough in cases of after-school care where nurses are needed, as Willem testified to. Additionally, education is meant to be an equalizer. However, in a city where chronic conditions are rising and healthcare coverage is dwindling, school nursing discrepancies have exacerbated inequity in public schools. Nurses aren't attracted to these over-demanding and underpaying cluster system jobs. All of this to say, DCPS and DCPCS have left students high and dry for the treatment of their condition-induced episodes. However, working with the Health Justice Club these past 6 months has taught me one thing. My low blood sugar episodes are spontaneous, but school nursing support doesn't have to be. When students, nurses, and teachers are struggling and suffering to this extent, change must be wrought. We believe the new resolution, which details many of the initiatives the Health Justice Club has supported, can work to bring student health back to the forefront of DC Council. By demanding that nurses earn higher wages and that schools provide opportunities for students to get involved in nursing, the shortage can be addressed from the root up. We acknowledge the actions that the Public School Health Services Amendment Act promises, but we also know that more is needed to help all DC students. From me and the rest of the Health Justice Club, thank you.
Thank you. Thank you all for the panel of witnesses and Capri and Brady. Thank you for your consistency in advocating on these issues and growing the Health Justice Club from something that just started at one school to now that has multiple chapters at other campuses across the city. So really, really appreciate that. It's always also good to have insight in terms of, I know what, DC Health provides us in terms of data, but what you're seeing on the ground in terms of who's showing up each and every day, I think is super important. So thank you for your testimony. Ms. Baird, thank you so much for your testimony as well. I think we had sort of contemplated around thinking about, there are some DCPS schools that are co-located with school health centers, which is a little bit different, but in terms of Brea, I hadn't thought about, you are co-located with Mary Center. Are all of the campuses for Brea co-located with the health clinic?
That's a great question. So our Adams Morgan site is located, shares a building, same with Georgia Avenue and Fort Totten. Our newest site, the one on Shepherd Street, is a block from the Georgia Avenue one. So the students who go to the Shepherd Street location have access to the Georgia Avenue clinic.
Okay, all right. So we'll just have to sort of think through that. Are you aware of any other charter LEA who is similarly situated?
I can't speak to that, no.
Okay, all right. Mr. Dickey, thank you so much for being here as well. This legislation, I don't feel like addresses your particular concern around after school. And we've raised this with the head of DC athletics or school athletics, because as we're getting younger with competitions, this definitely becomes an issue. And I think he was at a hearing earlier this year where he said, no, anytime that there is a sporting event or sporting competition, there should be someone who is present, who can provide health triage or whatever, if there is an incident that occurs. But it has not gone down to the elementary school level yet. It is for high school, it is for middle school. So we need to continue to work on that. But thank you for being here and your continued advocacy. Councilmember Nadeau, do you have any questions for these witnesses?
No, Madam Chair, I do not.
Okay, I think she said no. We can really hear. I think she just say no. Chairman Mendelson?
I heard her say no. Thank you. You asked a couple of the questions that I would have asked. Mr. Dickey, you referred to a bill to be introduced next week. Is that the same bill others referred to from the Board of Education? And do we know who's introducing that?
I'll turn you back on. Mike.
Microphone.
Sorry about that. So the State Board of Education, by passing a simple resolution, can introduce legislation into the DC Council. We spoke with Mr. Goulet, who is the Ward 3 representative on the state board. He had told me that, and he's testifying later, so he would be able to better speak to that. But my understanding is that this legislation is to be introduced next week as the first step. But you may, again, you may want to ask him about that. But this is a right. This is sort of a I guess little used backdoor way of introducing legislation to the council.
Yeah.
So,
all right. Let me see, Ms. Romney, you're a senior at Washington Latin?
Correct.
And Mr. Woodhouse, I didn't get where you were.
I'm a senior at School Without Walls.
And one other question, because this is not my committee, I don't know about testimony, but did you all submit written testimony? so I can get it from?
Yes, we submitted written testimony, and I also urge you to look at the written testimony of some of the students from the Health Justice Club who couldn't be here today because they weren't able to take time off school because of field trips and other happenings. But thank you.
Okay, so Health Committee will share the.
We haven't gotten yours yet, Brady. Did you guys you uploaded it online?
I'm pretty sure I did. I can go do it again though. That's no trouble.
If you guys would just double check on that, that'd be great. I think we'll just upload it. If you just upload it on the website. Okay.
Council's
Awesome.
website, the hearing management system, HMS, there's the ability to upload the statements, which would be a beautiful thing, because then I can read them. Thank you. Thank you all, each of you, for your testimony.
Thank you all for your testimony. Do you have any further questions? All right, so we're gonna go to the virtual group. This is crap. Okay, so I have 12 people who are signed up virtually, so we're gonna do 6 and 6. So Sarah Buckley, Rachel Johnston, Melinda Flynn, Danielle Nelson, Fraser O'Leary, and Kristen Yochum. Again, if this is the first time that you are testifying with us virtually, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up on your screen and you just gotta say yes. We'll give it a minute. Okay. Ms. Buckley.
Good morning. Can you hear me?
Yes.
Great. My name is Sarah Buckley. I'm a parent of 2 at Amadon Bowen Elementary School in Southwest. I'm also a member of Parents United for School Health. Until 2023, DC law mandated that every DC school be given a full-time nurse. DC Health failed to deliver that. And so, pointing to a nurse shortage, DC Health asked you to change the nurse mandate and open the door to the cluster model, in which nurses would oversee 4 schools, primarily staffed, with unlicensed health technicians trained to administer medication and follow directions. But DC Health again failed to deliver. Nurses fled the system, health technicians quit, and students were left behind. Today, we have half the number of nurses in the health suite system that we did in 2023. Today, you're hearing testimony on a bill that would codify and sanction that cluster model. At first glance, the bill increases from 20 to 30 the number of hours that a, quote, registered nurse might be assigned to each DC school. But what subsection A giveth, subsection B taketh away. Subsection B states that a combination of schools may retain other qualified health professionals supervised by a nurse to comply with the section A mandate. Health professionals is then defined to include health technicians. What the bill actually mandates then is less than full-time coverage, not by a nurse, and DC students deserve better. I have some questions about the bill. First, if DC Health has a fully staffed cluster model, then why is the mandate in the bill only 30 hours? And second, what does it mean for a health technician to perform duties under the appropriate supervision of a registered nurse? The question of appropriate supervision is important to answer before taking any further step down the cluster model road. DC Health does not currently have enough nurses to have true cluster nurses. Instead, we have RNs that are assigned as school nurses, pulling double duty by nominally filling the role of cluster nurse too. So what does supervision look like in that context? Even if the RN is able to review longer-term care or medication plans, how does she supervise the health technician on a day-to-day basis? How does the health technician get advice when a student presents with a new or acute medical issue? Are we assuming the existence of a telehealth line that DC Health told council was not funded and not operational last budget season? As an alternative, I urge this committee to consider instead the bill that will soon be introduced on behalf of the State Board of Education, which was passed as Resolution SR 2418, advocating for enhanced school nurse staffing and support in DC schools. It mandates full-time nursing coverage by 2028, creates incentives for nurse recruitment and retention, and calls for a year-by-year phased-in plan for adding nurses to the system. I appreciate that the attention that this committee has given to this issue, and I appreciate that the bill offered today is a sincere attempt to take some small steps forward on student health. But I urge you to hold DC Health's feet to the fire, toss the excuses, and demand concrete progress toward meeting the goal that I think everyone here agrees is the right one nurse in every school. Thank you.
Thank you. Ms. Johnston?
Good morning, Chairperson Henderson and members of the committee. My name is Rachel Johnston, and I'm a Ward 4 resident and the Chief of Staff at the DC Charter School Alliance, the local nonprofit dedicated to ensuring all students in DC receive the great public education they deserve. Charter schools are committed to providing safe and healthy learning environments for nearly half of the district's public school students. For that reason, I'd like to start by thanking Councilmembers Parker and Henderson for introducing this bill, which prioritizes access to healthcare at school, especially as our schools support communities where conditions like asthma and diabetes regularly create attendance challenges. We appreciate the opportunity to collaborate with the city leaders to ensure policies meet the needs of all schools and the students that they serve. We are also grateful to the Children's School Services team and its leader, Dr. Boudreau, for their partnership. This program currently provides more full-time health suite coverage than ever before to 92 charter schools. As a next step, we look forward to working with CSS to improve the consistency of the same staff in those suites because we understand retention is a challenge. This is necessary to build strong relationships with students, parents, and school staff. Finally, we'd like to recognize DC Health for supporting schools' efforts in keeping students healthy by making requested changes to the immunization compliance system. We believe this bill, with a few key adjustments, provides an opportunity to expand on the progress already made to serve students' health needs while they attend school. My testimony today will focus on 4 key recommendations we believe can strengthen the bill and create a meaningful path to implementation. First, we recommend adult charter schools be exempt from this bill. Adult schools are currently not eligible for the city-funded program through CSS. These schools also operate differently. Adult charter schools naturally have different calendars and daily schedules than standard pre-K through 12 schools. They often have evening classes and offer virtual, in-person, and hybrid options. This schedule is counter to CSS's. Our adult schools have independently put systems in place that support their students' health needs. They offer ways for students to access routine care and address chronic illness and emergency health needs. For example, Brea Public Charter School is co-located with Mary Center. The Next Step Public Charter School hires their own private nurse. Second, we recommend adjustments for the implementation timing outlined in the bill. To ensure DC Health, CSS, and charter schools have time to prepare, we recommend setting January 1st, 2025 as the deadline for schools to notify DC Health of their interest in participating in the CSS program. We then recommend the 30-hour coverage requirement go into effect on August 1st, 2025. A runway is necessary. Generally, we've heard from schools that the health suite approval process is complex and can take years to complete. And even after approval, the reality is schools then wait many months for staffing. We have 5 schools in that position now. These issues, coupled with a 13-page checklist for health suite requirements, have made it prohibitive for many schools, including our smallest schools, to complete the process. We thus currently have 14 schools who pay for their own nurse. While we strongly urge DC Health to work with our schools to simplify this process, we also offer an additional option. Our third recommendation is for the council to add an alternative opportunity to this legislation, a grant program run by DC Health that would provide schools with funds to hire their own nurses. This grant program could be structured similarly to the DBH pilot for mental health clinicians launched last fall. We'd like to thank DBH for creating this innovative alternative solution to staffing mental health clinicians. This type of program could create a pathway for compliance for schools whose buildings don't support a health suite that meets all 13 pages of requirements. It would also relieve some of the pressure from the CSS program. We have several schools that would volunteer to participate if such a pilot were made available. Our final recommendation is to further define the technical assistance outlined in the bill so it meets schools' needs. We believe the following technical assistance is most needed, some of which currently exists. First is timely priority access to training on healthcare systems and requirements like the Immunization Compliance Portal and DOSIS. This includes an initial orientation session. Second, is support navigating technical issues in real time, like when students are submitting their immunization records in compliance with No Shots, No School in the fall. Schools value the support assessing and entering health records in doses. And third is administration of medication training. Improvements to quality, efficiency, and access are essential. Currently, 377 charter school staff are AOM trained. This demonstrates schools are interested in ensuring staff are trained to support students' medical needs. But the current training program restricts the number of staff who can participate due to capacity limitations. We recommend DC Health identify additional AOM trainers that schools could voluntarily engage to train more staff and add extra capacity. In closing, charter schools value the health and well-being of their students. The DC Alliance is grateful for our partnership with the city, and we welcome the opportunity for continued collaboration to ensure every student's health needs are met so that they can actively and safely engage in learning. Thank you for your time and attention, and I welcome your questions.
Thank you. Ms. Flynn.
Hi, my name is Melinda Flynn, and I'm a parent of an 11th grader at MacArthur High School, the newest public high school in the city. Our family was honored to be given the opportunity to be a part of what will be the first graduating class of this high school. I am also the vice president of the MacArthur PTO and a member of the SIT working group to help with the ongoing construction and growth efforts of this school. Finally, I am a clinical social worker and assistant professor of social work at the University of Massachusetts, and I've practiced social work now for almost 25 years. It is well known that high school students essentially present for both social work and health services with many of the same concerns as adults. Complex health issues that often exist at the nexus of social, developmental, medical, and psychological concerns. But they're not adults. They are adolescents with rapidly developing brains and bodies. Having a licensed, registered nurse physically on site at every public high school full-time would go a long way toward ensuring the overall academic and psychosocial success of our public high school students. It is not appropriate for the school's social workers, teachers, or staff to be attempting to address these concerns for students. Also, in many cases, these nurses provide essential care that students would not otherwise receive. The stories of students who have testified before me speak much more eloquently than my words, and I'm grateful for the students' courage and assertiveness. I also appreciate the voices of those who are much more informed about this issue than I am, but I did want to add my voice as a DC public high school parent to strongly support this amendment. Thank you very much.
Thank you. Danielle Nelson.
Yes, good morning, Chairperson Henderson and other members of the council and committee. I am Danielle Nelson, work at Monument Academy Public Charter School as the Chief of Wellbeing, where we serve 132 students in a boarding school. We're in Ward 7, and our focus is trauma-informed education. So as a school leader serving in the role of our Chief of Wellbeing at Monument Academy, I am deeply committed to providing safe and nurturing learning environments for our students and the educators who support them. Their health and safety will continue to be a top priority. Monument Academy is not in the Children's School Services Program due to the structure of the nurses suite not being approved during the approval process. However, after budgetary, operational, and ethical consideration, Monument employed a full-time nurse, contracted an evening nurse, and supported 2 staff members to become certified administrators of medications. Monument's full-time school nurse and other contracted and certified nursing personnel are huge assets to our students and families. During COVID in 2020, our full-time school nurse showed great interest in serving our community during the pandemic, and she continues to provide students with quality school-based healthcare. I would like to highlight that our nurse worked tirelessly with our operations and family engagement departments and external partner agencies to help coordinate a robust COVID testing protocol using PCR and rapid tests. And Monument Academy successfully created a safe atmosphere during the pandemic, continuing to educate our students on campus and ensuring that all stakeholders were and remain the top priority. Fortunately, our nurse had prior experience with COVID testing from hospital settings, and her crisis training helped us to prevent outbreaks among staff and students by detecting and isolating cases early. Additionally, our school nurse successfully implemented practices to improve our immunization compliance rate from 20% to 90% since her hire date in 2020. Our nurse communicated and worked with the Department of Health, OSCE, Children's National Medical Center, and the Public Charter School Board to improve immunization rates. She also increased the number of our students' hearing and vision screening assessments by partnering with Children's National Medical Center and Elaine Ellis Health Services. Most importantly, our school nurse continues to focus on health education and raising awareness regarding childhood disorders and diseases. Our nurse continues to explore creative strategies to discuss risk behaviors and the importance of physical wellness, and she provides guidance around common issues from middle schoolers' development. Our nurse works closely with me as we strive to serve the whole child, whole community, and whole school. I have also served as the school-based behavioral health coordinator for the past 4 years, and it has been a pleasure and an essential practice to incorporate the nurse in the comprehensive school-based behavioral health services and the school strengthening assessment and work plan process. Due to the effective and efficient collaboration between the Wellbeing Department, staffed by licensed social workers and graduate level interns, and nurse services, Monument Academy was able to increase parent communication regarding student health observations, needs, and emergencies, conduct timely student assessments regarding sleep, dental, physical, and mental health and hygiene, and manage medication management issues. Lastly, the school nurse continues to assist families in crisis by linking families to community resources, navigating insurance barriers, participating in our interdisciplinary student support team meeting, and building trusting relationships with students and guardians as we combat sensitive issues and student health needs in school spaces. In closing, we would like to recommend the following: technical assistance from DC Health, timely priority access to training on healthcare systems and requirements, direct access to the systems, and initial orientation sessions and support navigating technical issues in real time. And we will also like to support for student immunizations at key moments during the school year, especially in the fall when students are submitting their immunization records in compliance with No Shots, No School. I want to thank you for your time and consideration and allowing me this opportunity to testify and advocate for Public Schools Health Amendment Act of 2024. Thank you.
Thank you. Mr. O'Leary.
Good morning, Chair Henderson, and all the other council members that are on this call. I'm Fraser O'Leary, the Ward 4 representative on the State Board of Education, and I'm testifying as a teacher and a parent. And these views are my own. Over the past 2 years, the State Board of Education has had many members of our community who are teachers, healthcare professionals, and most importantly, students, testify about the dire need that our schools have for full-time nursing care in all of our schools, the public and the public charter schools. As I speak, it is a fact that many of our schools do not have a full-time nurse. Last school year, there was a significant reduction of school nurses, which has been mentioned, because of many mitigating factors, such as competitive pay and more conducive working conditions. I am sure you are aware that many of our DCPS schools are serviced by a cluster of nurses who are responsible for the care of the students in schools to whom they are assigned. We spend a lot of our time talking about school safety, and yet many of our students go to school every day without a qualified medical professional in their second home. What happens when there is a medical emergency, such as an asthma attack or an epileptic seizure, and the cluster nurse is not there? We need nurses who can become a part of each school community, rather than nurses who are unable to bond with the students in the school. This is a problem that can be easily solved with forward-thinking legislation by the council. Last month, the State Board of Education voted unanimously on a resolution to provide full-time nursing in our public schools. SR 24-18 calls for a full-time 40-hour-a-week nurse in every DCPS and public charter school during normal and extended school hours. 40 hours. We strongly urge the legislation to upgrade its time limits. The council can take a giant step in ensuring that our children are able to have first-class health care during the school day by moving quickly on this, what we hope will be amended legislation. Thank you very much.
Thank you. Kristen? Okay. All right. I don't see her. Ash. Okay. All right. And Ms. Yoakum isn't here, but thank you so much to this panel of witnesses for your testimony. Ms. Johnston, I want to follow up with you and some of the things that you brought up in your testimony. We worked in concert with you guys and the Department of Behavioral Health to launch that pilot program that allowed for charter schools to be able to hire their own behavioral health folks in terms of filling some of the vacancies there. But I'm not necessarily convinced that this is the same type of situation, given, yeah, I'm not. Tell me why you all think that a similar type of program could work well here when in fact, I've got hospitals, I've got children's, I've got lots of places who are struggling to find registered nurses. Why do we feel like a charter school can figure this out on their own?
Good question. I think several of our schools are doing this work already. So we have 14 schools that have already gone down the path of hiring their own nurses. I mean, they've done it for a variety of reasons. Some of them have done it because they want full-time coverage from a nurse, from an RN, rather than from a health tech. Some of them have done it because they face space constraints in their buildings and are unable to meet the health suite requirements outlined by DC Health. And so I think we've seen this model work. Some of these schools have been doing this for years. The schools that are currently not engaged in the CSS program could benefit from having this opportunity to provide health suite coverage in a way that works for their existing model.
Okay.
I don't know if that's the answer that you were looking for. I think
I mean, I'm open to, exploring a variety of different models in terms of, I think there are other types of benefit structures, et cetera. I do find that the behavioral health piece was unique in that, at least knowing from some of the charter LEAs, it's not just the salary piece. It's, they give certain hours to folks for supervisory hours that goes towards licensure. Like there is a great sort of package and interest that you can sort of put together. I just kind of feel like with nursing, but I don't know, I'm open to a variety of different ways in terms of how we kind of address this particular issue that we're seeing.
If you don't mind, I think there's one other thing that I probably want to add to that.
Sure.
We have several schools who have gone through the health suite approval process and are still waiting for staffing. And so I think there's also an opportunity with this type of program to relieve some of the pressure on the CSS program. So they could find nurses from alternative hospitals and from alternative programs that could staff their suites quicker.
Okay. All right. Thank you so much for that. Mr. O'Leary, thank you so much for being here and for the work that you do. I think some of the witnesses on the previous panel maybe tipped their hand in terms of the board's interest in introducing legislation to sort of get back to 40 hours a week. That was law in the district until 2020. We were unable to meet that partly because of staffing and budget. And you know, when you talk to your colleagues who are in surrounding jurisdictions, and not all of them do have 40 hours a week of nurse coverage, are you talking about this issue and what are they saying that they're doing differently that we're not doing here?
I don't talk to people in that many people in surrounding jurisdictions, but I know what I hear from our principals and our teachers and the educators in the city who don't have a nurse in the school, and the ones that do have feel blessed that they have those nurses in the schools. And I just can't imagine from the testimony, we heard testimony from not just in the city, but from the United States about how important nurses are for the everyday life of the school. And that's to me where I come from. I have 5 children, and I was lucky enough that all of my children had nurses in their school. And I just can't imagine as a coach or as a teacher, not having someone in the building that can take care of somebody in an emergency. That's why I brought up school safety, because when we talk about school safety, we talk about sort of outside the school safety kind of thing. But, you know, for someone who's been involved in a situation when a child had an epileptic seizure, I know firsthand what the emergency is and how important it is to have someone who knows what they can do. And besides, those health techs can take care of it, because the health techs don't have the authority to do a lot of things in the schools.
Thank you, Mr. O'Leary. I mean, we've had several hearings on school health services. And thank you, Ms. Buckley, for being here and for your consistent advocacy on this, as well as Ms. Flynn, who's testified before. And I asked children's at one point, like, how much would it cost, right? Not just for them, but for anybody to do it. So we're talking about a $35 million program in order to do school, a full-time nurse in every school. And what was so interesting, and even then, whether it be children's or others, they said, you could give us the 35 million and I probably still won't be able to find a school nurse for 162 different campuses because of the availability of them existing. And so I think we're trying to figure out how do we provide coverage in a very similar manner of on the school-based mental health or school-based behavioral health program. We provided additional funding for it. There is funding available for every school to be able to have a person, and we are still only at 60%. So it's like, and I'm not saying we shouldn't have the goal, but in the absence of me being able to put a nurse in every school, I think what DC Health is trying to do is saying, I need to have somebody in the building who is qualified and who is trained, who can provide some of these things. And so we continue to sort of work on this issue. I'm over by time. Councilmember, Chairman Middleton, sorry.
Thank you. I want to thank each of the witnesses. And if any of you haven't submitted your statement, please do so that we have that. I had a few questions for Ms. Johnson.
Yes.
I think I'm going to do this in sort of in the order of your testimony. So you mentioned early on, grateful to Children's School Services, which is to Children's National Hospital. I understand they get a grant. I remember in the past talking to somebody from the charter sector, they thought a contract would be better. Do you have a view, grant versus contract?
Not necessarily. I think my understanding is part of the reason for that had to do with some of the requirements and stipulations outlined. I think what we just want to make sure is that our schools have the full-time coverage that they've been promised and that their students have access to their health care.
Okay, I think that a contract is more prescriptive. And so, for instance, I think there's been an issue in the past where a school would not have the same nurse day after day or week after week.
And that is actually a challenge that several of our schools are still facing, is consistency of the coverage that they're getting. While they now do have full-time coverage, by and large, they're seeing turnover. And so that consistency piece is really key.
Chair Henderson, was pressing you with regard to, I think, the suggestion for a grant program similar to the Department of Behavioral Health. My reaction is a little bit different, and that is, yes, so maybe a charter school should be able to go on their own with regard to getting a nurse. And I think that's the essence of what you're suggesting there. But what if they fail to hire? So they're exempt from the DC Health program, and because they're going to have their own nurse, maybe through a grant, maybe without a grant. I'm sure a grant would be preferable, but maybe without a grant. But what if they fail to hire?
So I think there are several organizations out there that are already supporting this work with our schools. So as I mentioned, we have 14 schools that are already doing this work, and our understanding from working with those schools and from communicating with some of the organizations that are supplying those nurses is that wouldn't necessarily be a problem if the schools could afford the nursing staff.
But you don't think that would be a problem?
No.
So I want to press you a bit on the health suite approval issue.
Yep.
Now, I don't chair the health committee. I'm not on the health committee, so I'm not really very familiar with this. But you testified health suite approval process is complex and can take up to 2 years to complete. That seems like way too long. Is that defensible?
I agree, it's way too long. So what we've seen, to just elaborate a little bit, what we've seen from some of our schools is that they'll get their health suite set up, and then they'll go through the inspection process. DC Health will outline a series of things that need to be changed. They'll come back for another inspection. The school will have to make the changes. They'll come back for another inspection and outline a series of different things that need to be changed. And so it was an iterative process, back and forth and back and forth and back and forth until it finally gets approved. And so I think there's opportunities to make the process a bit more efficient. And I think also the length of the health suite requirements list can be prohibitive for some schools to get through that process.
So are you saying, I'm putting this more bluntly, that in the inspection process, that in the iterative process, the requirements change?
They have. And so, for example, we had one school where the cot was purchased and put in the suite, but then DC Health came back and said, we are looking for a specific brand of a cot. So they had to go back, but that wasn't specifically outlined. Or they have a countertop space, but the checklist didn't have the specific length of the countertop space, but then DC Health wanted a specific length. So I think it's just been a lack of clarity on some of the requirements that have come through the list that has made it challenging for schools. I think the other piece of this is we have schools of varying sizes. And so the requirements are very standard, regardless of whether your school serves 100 students or 700 students, which can make it a little bit challenging to meet some of the space with their space constraints, to meet some of the requirements as they go through the inspection process.
Let me just see if I have any other questions. I do not. Thank you. Thank you to each of the witnesses for your testimony.
All right, thank you all for your testimony, and we're going to go on to the next panel of witnesses. All right, well, Kristen Yurkum has rejoined, and so we'll have her. Justin Lisak, Rachel Kimbico, Libby Bukel, Melissa Beasley, Laura Fuchs, and Eric Goulet. And just to forecast to folks where we're going, after we finish this last panel of witnesses, we're going to take a 5-minute break, and then we'll come back and do the government witnesses. Okay, I see Kristen, so why don't you go ahead and provide your testimony.
Thank you. Thank you for hosting this hearing today and for your continued consideration of student health and well-being. My name is Kristen Yocum, and I'm the Executive Director of Operations at Powell Public Charter School located in Ward 4. We serve over 750 students in grades 5 through 12. We're a longtime member of the Children's School Health Services Program and currently receive less than full-time coverage from an LPN who is a beloved member of our community. We've been told that we should not count on continuing to receive this level of care for the entire school year. Our LPN may be reassigned and we would receive support from a health technician. While we strongly agree that Paul and all schools should receive a minimum of 30 hours of nursing care per week, we do not believe that this bill and the cohort approach to school nursing will actually improve the provision of healthcare in schools or ensure that schools receive 30 hours of nursing care per week. In theory, the cohort approach allows a single nurse to provide oversight to the highest needs cases at multiple schools. In practice, in our experience, the RN in our cohort has often been tied to the campus she's based at because there's at least one student who must receive care that only an RN can provide. While our campus has 768 students, none require a medical treatment that only an RN can provide. This means that many days our health suite staffing is provided by an RN or LPN over the phone from another school. This bill does nothing to change that level of care. It allows a cohort to receive 30 hours of only phone coverage support from an RN. As you might imagine, phone coverage does little to support a child facing a medical emergency. The other healthcare providers on a cohort team, the patient care technicians, receive all of the technical training to provide basic care, administer medication, and maintain treatment records. There are some really great patient care technicians in the Children's School Health Services program. Unfortunately, they are being stretched to the limits of their training and ability. A PCT cannot possibly manage the healthcare provision, record maintenance, and emergency care of over 750 children on their own. While the cohort approach seems like the only solution on paper, RNs and LPNs get frustrated at not being able to provide the services that all the students in their cohort need. PCTs get overwhelmed without the support they need from RNs and LPNs. Everyone's burnt out and no one feels like they're getting the support they need. Every great school nurse I have worked with has been clear when they leave. They were not quitting nursing. They were not quitting the school. They were quitting the Children's School Health Services program because the expectations placed on them were too great. Without a massive concerted effort to retain good school nurses in the Children's School Health Services program, no approach to staffing and scheduling will be successful. The cohort approach also takes a significant toll on the school staff who are required to maintain medication administration and emergency first aid certification, but also in ways that aren't obvious. When the cohort approach means that a different health professional floats to the school every day, there's no one to maintain the suite, make sure the necessary supplies are there. There's not one person who knows that this student needs to be called when it's time to get her medicine, or that one needs an extra minute to calculate his sugars first. This all falls to school staff who have to take time away from the services they are meant to provide support to the health suite, even when someone from the Children's School Health Services program is there. Our schools do need more care provided by school nurses. In practice, however, this bill would simply continue the provision of care via phone coverage without addressing or creating any incentive to address the underlying problems facing the Children's School Health Services program. Thank you for allowing me to testify.
Thank you. Mr. Lisak?
Hi, thank you. And good morning, Chair Henderson, Chairman Mendelson, and other members of the council. My name is Justin Lessig. I'm the Executive Director at Sojourner Truth Public Charter High School, or Public Charter School in Ward 5. Sojourner Truth is the district's first and only public Montessori middle and high school. We're continuing to grow, and we currently serve about 300 students in grades 6 through 11. And next year, we'll have our first ever graduating class of 12th graders. Truth is a member of the Children's School Services program, and we're super grateful for the coverage we get, albeit less than full time, from a really, really wonderful nurse that has become a truly integrated and loved member of our community. I want to express my gratitude to Council Members Henderson and Parker for introducing the Public School Health Services Amendment Act of 24, as it prioritizes incredibly important access to health services at public schools around the district. On any given day at Truth, we have students who see our nurse for everything ranging from blurry vision and a need for glasses, to complications due to diabetes or asthma, to accidents that happen at recess or in gym class. We're thankful that DC Council is prioritizing the ability of schools like Truth to continue to have access to a nurse. One thing I am a little nervous about, however, is the cohort approach and the potential lack of access to a physical on-campus presence. I totally understand the shortage that Chair Henderson, you were talking about, and I certainly don't have a solution or a silver bullet to that. But my understanding is that of the amendment is that it would allow phone coverage to count towards the hours of support. a school is receiving from a nurse. This does feel a little concerning, as our nurse has often had to deal with emergency situations like injuries where a physical presence really is important. An additional concerns around the timeline and approval process that has been brought up to qualify for a nurse through Children's. So the approval process for health suites, for example, can be confusing. It can be a little onerous. Sometimes there is that significant waiting period to be staffed with a nurse, even after the facility receives approval. And we were lucky. We do have a building that met approval. But I can imagine like situations where if the facility does not meet all the requirements, a school then might have to hire their own nurse without that funding support. So if possible, it would be great if there were a way for schools in this situation to access funding, even if at some sort of modest level, to support them as they may hire their own nurse. Rachel from the Charter Alliance, that model similar to the one DBH created does seem like it might be something towards a solution, or at least helping with that, or offer some relief to schools that otherwise might be left entirely on their own. I know I don't understand all the complexities that I know the committee is studying, but I do wonder if like that grant style approach might help schools that don't meet all of those children's requirements for space, but maybe they are still able to contract with like another registered nurse that would find whatever space they have, counter space, number of restrooms, number of cots or private rooms. Maybe it would be satisfactory to certain RNs that maybe could be hired. So thank you for the opportunity, as always, to speak today. Thank you again to all the members of the council for the ongoing support for schools and particularly health needs. Thank you.
Thank you. Rachel?
Good morning, Chair Henderson, council members, staff of Committee on Health. My name is Rochelle Kimboko, and I'm the founding executive director of DC Wildflower Public Charter School with facilities in Wards 7 and 8. I'm a Ward 5 resident and have also lived and worked in Ward 8 for many years. Bill 25-0690 would require all public schools to have a minimum of 30 hours per week of nursing coverage during the school year and summer school. I wholeheartedly support the intention of council members Parker and Henderson in introducing the bill, but for a school of our scale and model, if it remains unfunded, it will have a negative financial impact on us. To be clear, we have already been told that we're not likely to receive health services from Children's for several reasons. First, we don't have health suites, and that makes us ineligible to participate in the school health services program. The guidelines for health suites suggest a minimum of 660 square feet with a separate waiting area. Neither of our 1 or 2 classroom micro schools, both around 2,500 square feet, can add a health suite and waiting room. At our current leasing rates, incorporating space for a health suite could add nearly $24,000 to our annual lease. Since it's already challenging to make facility deals that work within the current facilities allotment, I worry whether we could afford larger properties. Second is our enrollment. Even at scale, our enrollments are likely to be less than 60 students at each facility. Even at full scale, we'll still be a very small school, around 225 students. But because our sites will be located across 4 wards, potentially, it's unclear whether we would be asked to hire multiple nurses. My colleagues in the charter sector have shared that they spend on average $2,000 per week for contracted nurse support. So that's about another $75,000 in a full school year. I'm sure I don't have to explain the consequences that spending nearly $100,000 more for a nurse and suite would have on our budget. Even more devastating if every site has to support their own nurse. Finally, to the provision of care. I've heard several people mention having access to behavior tax or health techs. Again, because we're not participating in the service, we weren't offered those. Our school staff have AOM certification, and they are already meeting many, if not most, of the objectives that are part of the school health services program. So they routinely assess sick and injured students, provide acute care, do medication and treatment administration as instructed by a child's doctor, and monitor chronic health conditions like asthma. I recognize, I do In 2 years of operation, the only medical emergencies we've experienced occurred after school, which is a time when we wouldn't have had a nurse on site anyway. I do acknowledge that we are missing out on the specialized nursing service that several people have mentioned. There's a coordination of care, a developing of individualized health plans, and participation in interdisciplinary school teams that are working for students, IEPs, and 504s. The current model allows at least one nurse to work in consultation with a range of other health professionals to meet the minimum nursing requirements. I do wonder what alternatives there might be in creating a similar model to leverage AOM certified school staff. And then in closing, I have a few suggestions or questions for technical assistance that might support a very small school in providing better health coverage while school is in session. Please continue to make AOM administration of medicine training available and allow us to train as many staff as possible so that we can ensure we always have someone in the building who can respond in an emergency. Continue to allow small schools that are near each other to share nursing staff. Ask DPH to facilitate creating memorandum of understanding so that our micro schools can access a school nurse at a nearby charter or DCPS facility. Even if it's on a fee basis, it's less than us hiring our own nurse. Consider offering telehealth and similar access to medical professionals for situations that exceed the AOM training for those of us who are not in the school health program, and consider creating a supplemental allotment to the UPSFF that would help small facilities to absorb the additional cost of hosting a health suite. I thank you so much for your time and consideration. I want to reiterate again my support for making better healthcare available to all students. I understand the importance of it and just hope to share why it can be difficult to do at this scale.
Thank you. Libby?
Sorry, I didn't realize I needed to unmute myself. Okay. Can you hear me okay?
Yes.
Okay, great. So hi, good morning and nice to see everyone again. Thanks for bringing me here. My name is Libby Buckley and I'm one of the co-coordinators of Parents United for School Health. I've raised 3 kids in DC public schools and I still have 1 kid at Jackson Reed. In the 20-teens, my mother was experiencing serious health issues. She lived over 500 miles away and I started going to visit her frequently to support my sister and help care for her. During that time, one of my kids started experiencing a series of health problems, headaches, stomach aches, trouble sleeping, etc. And they spent a lot of time in the nurse's office. The nurse at Bancroft Elementary School was wonderful. She knew all of my children's names and she knew who I was. And she quickly figured out that my sick kid was not sick, but experiencing anxiety related to my sudden departures to care for my mom. She brought in the counseling team, she explained the problem to me, and the counselor at Bancroft did regular check-ins with my child. We made a plan. This competent, caring, reliable, experienced, and ever-present nurse at Bancroft helped calm my child and averted a budding mental health crisis. Everyone should have this experience. This is why I'm concerned about the bill that is currently before City Council. While I applaud the extension of requiring extension of nursing hours from 20 to 30, the legislation weakens this standard by allowing CSS to allocate just 1 20-hour per week nurse per cluster, not for school. This is insufficient. It doesn't even meet the minimum CDC requirement for 1 nurse per 750 kids because many of the clusters exceed that number. We need to add more nurses over time so all children can benefit from receiving the same care that mine received. Speaking of accountability, the bill requires CSS to submit data, but doesn't define what that means. How will we know if this model was working? So here are some suggested measurements. The first measure that we should use is whether CSS is actually ensuring that each school has staff in their health suites. CSS and DOH have said most schools have coverage, but do they? In September, Parents United for School Health held a Find Your Nurse Tech campaign where we asked students and parents to check if there was a staff member in their health suite. We received 17 responses from 16 schools, charter and public, including Ward 1, Ward 3, Ward 4, Ward 5, and Ward 6. The survey showed that over 30% of the health suites were not covered on the day in question. Who is holding CSS accountable? And I did a cute little graph in my testimony that you can look at for this. The second measure is consistency. As you saw from earlier in my testimony, parents and children should know who their Health Suite member is and how to contact them, and they need to have the same person regularly to build trust. Our survey found that more than half of those who responded to our survey, almost 60%, said they didn't know the staff member in their suite. The system seems unstable. The third measure is whether CSS is communicating with parents about the distribution of resources for each cluster. Parents and families have the right to know whether the school they have chosen for their kid will have staff with the skills necessary to protect their health. And parents with a kid with an IEP or 504 should be informed if there's no coverage on a given day. CSS needs to expand their community outreach model to communicate with affected parents and children. The fourth measure is whether the cluster model is currently living up to its promise to have one nurse manager, 4 techs, and 1 cluster nurse who oversees the care plans. Last year, there were 47 clusters in 185 public and charter schools. I understand this year there are 215 schools. There's only 44 nurses left in the system. That's not enough nurses to cover each cluster. And because CSS doesn't have enough techs either, the remaining nurses are working full-time in schools. This model is not actually what is going on right now. There's no cluster nurse overseeing the care plans. CSS needs to be held responsible for finding and providing nursing coverage until the cluster model has reached its minimum staffing nurse goals. And then CSS should continue to hire nurses. This is worse than before this model was implemented. I worked as a health center manager in a community-based health center in DC for 6 years. The clinics where I worked had excellent medical assistants. They get more training than the techs in the CSS model, but they were trained to work under supervision of a nurse or a doctor. They were young and inexperienced. In January, Dr. Boudreau said that even seasoned nurses struggle with being in a school setting. How are these nurse techs supposed to do this job without on-site supervision? They have no one to turn to. These young people are being set up to fail. We need nurses. The district should actively work to solve this nursing shortage, and I kind of wonder where the money is going, frankly. There are a lot of nurses in this area. The average salary of nurses in the district is between $98,540 and $124,279 per year. In January, the budget for this program was $25 million. We could hire 215 nurses for this amount. So where is this school money? Where is this money going? Are the school-based health centers also funded from this grant? We need to pay more to hire qualified nurses. It would be worth it. Nurses are important and essential. My nurse benefited from having one at their school, and that's why I strongly support the bill that the State Board of Education has proposed, which would create a glide path to 1 nurse per school while creating accountability. We need a long-term commitment from council to ensure that the nursing program is implemented so that we don't get let down like we were let down by non-implementation of the bill in 2016. Thank you.
Thank you. Melissa?
Hello, a lot of my testimony will align with a lot of what you've already heard. My name is Melissa Beasley, and I'm the Health and Wellness Director for E.L. Haynes Public Charter School. As an LEA, I support over 1,100 students in grades pre-K 3 to 12 at 3 campuses in the Northwest District of Columbia. E.L. Haynes takes pride in being a learning community where every student of every race, socioeconomic status, home language, and ability prepares to thrive in college, career, and life. In my role, I ensure that children in our schools receive the health and wellness support required for equitable and appropriate instruction access. Additionally, I monitor all students with special healthcare needs, their health, medication administration, and immunization compliance. School nurses are essential to this work. And while we strongly agree that all schools should receive a minimum of 30 hours of nursing care per week, we do not believe that this bill and the cohort approach to school nursing will improve the provision of health services in schools or ensure that schools receive 30 hours of nursing care per week. Our organization endorses this bill with the hope that it will encourage further conversation about the present gaps and deficits in service delivery. During my 4 years as director, I've seen the benefits of a dedicated nurse to our campus, actively engaged in safety planning and 504 IEP meetings for students. However, the frustrations with the cluster model, which forced that same nurse to leave the position and the school she loved, were equally evident. We have also experienced one of our campuses going nearly a year without a dedicated nurse and having infrequent coverage. This does not consider the students who do not have coverage during extended day or out of school programming. We have done our best to increase the number of our staff certified in the administration of medication training. However, it has been extremely challenging as those training offerings are rarely publicly shared. And when the school does receive a response, there are very few slots available. I fully appreciate the impact of staffing shortages, as my staff are primarily social workers who similarly experience the same issues with turnovers and hiring challenges. However, the cluster model is a Band-Aid solution that needs to be more effective for the nurses and the children they serve. Being connected to campus and building relationships with students and multidisciplinary teams has a monumental impact on the school community. Additionally, it allows students and teachers to focus on learning. It will enable parents to know that their children are safe and have care. Access to nurses in schools is an exercise in equity, ensuring that every student, teacher, and family has access to what they need to thrive in their chosen life. Hopefully, this legislation and future legislation will expand opportunities for all DC students experiencing health issues that reflect our nation. Our school has had an increase in students with pediatric diabetes, severe asthma and allergies, seizure disorders, and other diagnoses that require the support of a nurse. As for recommendations, I've already mentioned that administration of medication training is a big issue. I have diligently myself sent email after email after email requesting opportunities to have staff trained to support this coverage. And as I said before, it's an issue. So that's my time, and thank you.
Thank you. I don't see Ms. Fuchs or Mr. Goulet. Okay. Oh, sorry. We've also been joined by Maria Blauer, who's from our earlier panel. Maria?
Hey, thank you so much for accommodating me this morning, Chairperson Henderson, and good morning to everyone there, and Chairman Mendelson and other members of the committee. My name is Maria Bloyer, and I am the Director of Programs and Outreach at Advocates for Justice and Education, also known as AJE. AJE is the federally designated Parent Training and Information Center for the District of Columbia, and we are also the Family to Family Health Information Center for the district. Each year, we assist hundreds of families through direct services, training, and advocacy in navigating the district's public education system, but also the healthcare system, with a particular focus on the needs of students with disabilities and special healthcare needs. Today, I testify in support of the Public School Health Services Amendment Act as it was characterized by Councilmember Parker, a first step in a much longer journey. AJE feels strongly that in-person staffing, full-time in-person staffing by an RN or an LPN should be the standard. That should be what we are reaching for. Failing that, we ask that the committee work closely with DC Health to establish meaningful guidelines for staffing and supervision models that actually meet the needs of schools, students, and the professionals serving them. We also ask that you work with DC Health and the education connected executive agencies to reduce barriers to participation in the school health services program. My testimony today is informed, one, by our work with families, especially those families whose children have chronic or complex health needs, whose children require services at school that need to be delivered by a trained professional, typically a registered nurse, but sometimes also someone trained who's received the AOM training, or who have conditions that may require emergency medication, emergency administration of medication. These families struggle tremendously have struggled tremendously in accessing their children's education as the result of the school nurse shortage. We want to be flexible and think of ways to make sure schools actually have the support and understand that school nurses aren't going to appear out of nowhere. But it's also incredibly important that whatever staffing model is put into place works and is effective and actually meets the needs of students in schools. And I think we've heard all morning about how it's not doing that right now. The challenges identified today and by the families we work with are also reflected in our community health survey, where it's just made incredibly clear that the school and the school nursing program is a vital part of a child's broader network of care, and one where effective communication and collaboration between families, schools, and providers is particularly important. We strongly support the expansion of the requirement to have 30 hours of school coverage, regardless of whether or not of school nurse coverage, regardless of whether or not a school participates in the school health services program. And we also support the technical assistance that this legislation requires DC Health to offer schools that aren't participating. But we also know it's just the first step. That technical assistance is not going to be adequate to solve the problem. We read DC Health's testimony with great care, and they are very correct in their reading of the legislation as it's currently drafted. It does restrict who else can work in a student health suite. And we think that's probably a good thing. Students need trained professionals in the classroom, in the classroom and in the health suite. And failing that, the people in the health suite need to be adequately supervised by licensed professionals like registered nurses. So as I mentioned, our perspective on this legislation is one, as a first step. It's informed by our work with families, but it also, I think, is very consistent with some of the other comments you've heard today. And I just want to highlight those areas of commonality in my last moments here. First, I want to point out that the AOM training that the Charter School Alliance pointed out at needing, that we've heard from several other providers today, that AOM training is needed. We agree 100%. Failure to have trained staff results in children missing school, being unable to access the fullness of the school experience. And I just want to share anecdotally that schools and parents and teachers want this training. They're asking for it. They have called AJE and asked us to provide it, which we are wholly unqualified to do. But that's how desperate they are to get it. So I think it's just incredibly important that we grow that. I also think that the testimony we see from Paul Public Charter School and Capital City Public Charter School just make it very, very clear the actual impact on the lived experience of schools and children, this shortage. And we really encourage you to look at this bill, move it forward, but also think of it as the very first step in a much longer journey towards a more robust staffing system.
Thank you so much. Thank you to this panel of witnesses for your testimony and for being here. I do have a couple of follow-up questions. Ms. Beasley, I'm just curious. So E.L. Haynes has 2 campuses, technically 3 schools. Do you have a nurse for each campus, or is there one shared amongst all 3?
We have one shared between our high school and our elementary school campus, and the middle school campus is the place where we have a tech, and often, sometimes infrequent coverage, mostly not a lot of coverage.
Okay. All right. And I'm just trying to, I think Justin had to run to a meeting. Ms. Kimboko, I feel like DC Wildflower situation is fairly unique in sort of the micro school model. Do you all still comply with needing someone, at least 2 people on the campus to have had administration of medication training?
Yes, we are doing our best to do that. It is challenging to accomplish at the current pace because we can only send one person at a time. So that, I will say it this way. I expect that by January, we will have exceeded that. But we also want to make sure that we are covered after school, because that's, that is ironically, not surprisingly, that's the time when a lot of surprise injuries happen.
Yeah.
Kids get, exhausted, whatever. Those are the times when we have the most likelihood of an emergency. But yeah,
Okay.
between and everybody has CPR or first aid. So at the very least, we can do that. But being able to do medication is even more important, I think.
Okay. Yeah, no, I agree too. So I'm relieved to hear that you all are still doing that, recognizing, the health suite guidance is, well, it wasn't designed for a micro school type of environment. It's just sort of the guidance that is given. And I will say this too, because I think that Mr. Lessick brought this up in, from Sojourner Truth Public Charter School. We have been trying to work with DC Health to get very clear in terms of what you're requiring for the public school health suites, right? Like if you want a particular brand of, I don't know, curtain, say that. Don't just say curtain and then like we have this sort of back and forth of whack-a-mole. Just say what you want. And I feel like schools will do their best to sort of meet that. I think there are some other pieces and requirements there that, I don't think DCF was ever gonna back off of around like needing to have a water source for a nurse to be able to sort of, I don't know,
Yeah,
wash
I
their
mean,
hands and do those kinds of things. But
yeah, I can double click on that. The experience that Rachel mentioned of it taking, nearly a year for a health suite to get approved was also my experience at Lee East End. I was the assistant head of school when we launched that campus, and it took us forever to get through that process. Even though the building had already been built as a school, it
Yeah.
still took us a long time to get that health suite approved, which is it's a problem, but.
okay. I wanted to ask, there was a public witness who brought up earlier, and you sort of mentioned this a little bit, Rachel, around like the after school piece of things. Miss Yoakum, and Miss Beasley, you both have, Paul and E.L. Haynes both have upper grades. So, middle and high school, what does coverage in sort of the health realm look like after school or when you all have sporting events?
At Paul, it is entirely provided by school staff. So administrative of medication and school staff who are trained in first aid, CPR, AED.
Okay. Miss Beasley?
That's the same for E.L. Haynes. And we have had some challenges in terms. The other part of this is that we're talking about the nurses and their turnover. But our staff that received the training may have left. And so therefore I'm trying to replace those staff with trained staff. And so I think there's a presumption that, oh, well, you guys already had people there. Well, those people may have left. And so now we don't have that coverage. And so I'm speaking specifically around our after school program, our out of school program and extended day programming. We're not meeting the criteria right now for administration of medication certified staff for those after school hours. So it is a problem right now.
Okay. I'm over my time. Chairman Mendelson?
Thank you. Thank you to each of the witnesses. I had some questions for Ms. Kamboku, and I think Chair Henderson went over some of this, but I'm going to plow ahead anyway. So I think you testified that Wildflower has maybe 60 students at each facility?
Our largest, well, we only have 2 right now, but the first facility at scale, 2 classrooms will be about 60 students. And I currently don't anticipate that any of our future locations will be bigger than that, because that's 2 classrooms. So you can imagine we're growing 1 or 2 classrooms at a time, but we're growing across multiple facilities instead of in one place. So that presents a little bit more of a challenge to figuring out where a nurse is going to sit, even if we had one.
Sure, and you're a small school by design, correct?
Yes.
So what should be, theoretically, the health care that you have for students? I get what you said before, that a suite which I think is like 2 rooms, 3 rooms. I mean, it's almost like the size of your school.
Classroom, yeah.
So what should it be for a school of 60 students?
I mean, I think it's a conversation I would love to have with health professionals. I will say we have been really, I feel really well supported by the team, Sharon Bostic and Deanna, lost Deanna's last name, who have really been great about helping us think about how we take care of our kids, right?
And those 2 individuals are from where?
I think that they are Aussie. I believe that they're Aussie Health folks, but they
Okay.
may now be at DC Health, or they bridge.
They're contracted by DC Public Charter School Board to support charter schools.
Deanna was at Aussie before that, though, right? Okay,
Yes,
got it.
previously.
So what's been interesting is, Sharon is a nurse and runs a service, and her recommendation to us, if we could afford it, is for us to try to find a private nurse, as Justin said, find a private nurse who would be willing to work with us, and give us an equipment list and make sure that we have the equipment on site that would be necessary for a nurse, so that when that healthcare professional does have to come to campus for whatever reason, they have the tools that they need to proceed. I can also imagine that in one of our next facilities, we do make sure that we have space for a health suite, so that there is a place for a nurse to go. But I feel as a parent, I absolutely understand the reassurance of having a school nurse on hand always. And my experience as a school leader has been that we have not failed to serve our children's healthcare needs. So they're somewhere in the balance, I think, is the answer. If we had better access to someone who could help us troubleshoot when something happens that we're not comfortable making a decision about, I think that would be really helpful.
So more of an on-call model.
I think so. I know that telehealth is one of the options that's available to folks who are participating in the program. I think that would be great. Or honestly, we are literally 2 blocks away from a public school, and at our other location, we are across the street from a public school. If we could find ways to forge partnerships where if we have a really sick kid, we can walk a block, or get that kid to that campus and get support from their nurse, that would be amazing, and I would be willing to pay for it. But that's, I know, that is possibly an aspiration that's going to need support from other quarters to make it happen. But that seems like a pretty simple solution to me as well.
Thank you. That was helpful. Thank you again to each of the witnesses.
Thank you so much to this panel of witnesses. We've actually just been joined by Eric Goulet, who's the Ward 3 representative on State Board. We're going to give him an opportunity to present his testimony. Mr. Goulet, when you're ready.
Thank you. Can you hear me, Chair Henderson?
Yes.
I want to really appreciate you accommodating me and allowing me to testify today. I apologize for not being here when I called. I was in a important meeting here. I'll begin at this time. Good morning, Chairperson Henderson, council members, and council staff. My name is Eric Goulet, Ward 3 representative for the DC State Board of Education. I am delighted to join you at today's Committee on Health public hearing to provide testimony on Bill 25-0690, the Public School Health Services Amendment Act of 2024. I will be testifying in my individual capacity as Ward 3 representative today and not on behalf of the collective board. DC's school health suites are currently in a downward spiral due to non-competitive salaries in the DC Health Children's School Service Program and a cluster model that is causing registered nurses to flee school nursing here in DC. In just one school year, DC saw a decrease from 82 RNs in school year 23-24 to now just 44 in school year 24-25. While I think Bill 25-0690 is well intended, it is a harmful piece of legislation, and I speak in firm opposition to its enactment. Although this legislation increases the required number of hours a school health suite must be staffed from 20 hours to 30 hours, it also reduces the professional qualifications of the person staffing the school health suites by codifying the use of health technicians to meet the hourly requirement. The bill also codifies the increased use of the cluster model, which has contributed greatly to the precipitous decline of registered nurses in our DC school system. Parents and students want and deserve a full-time registered nurse in every DC public school and every public charter school. On September 18th, 2024, the DC State Board of Education unanimously passed a resolution advocating for enhanced school nurse staffing and support in DC schools. This resolution also approved two appendices, one sending a letter to DC Health requesting additional information, and the second transmitting a bill to DC Council for introduction by Chairman Mendelson at the request of the State Board of Education. SBOE's legislation, which is attached to my testimony, is entitled the Universal Full-Time Public School Nurse Requirement Amendment Act of 2024. The bill requires that by August 1st, 2028, DC shall have a full-time 40-hour per week nurse that's an RN in every DCPS and public charter school, thus eliminating the use of the failed cluster model. To achieve this goal, DC must increase the grant funding provided to children's school services and ensure that the additional funds are used to increase salaries of our nurses. Based on testimony at the committee's January 4th hearing, it will require an increase of roughly $7.5 million per year for each of the next 4 fiscal years to achieve this goal. Additionally, the SBOE bill creates a school nurse retention loan repayment program, which is modeled after the loan repayment program currently in place for DC medical professionals practicing in medically underserved areas of our city. This program would provide RNs working as DC school nurses up to $10,000 per year to pay student loans. And coupled with the salary increase, loan repayment would serve as an additional incentive, allowing DC to retain nurses in our public schools. Parents do not view health technicians or licensed practical nurses, which are LPNs, as an acceptable substitute for a full-time 40-hour per week RN at their children's schools. The DC government is spending tens of millions of dollars on unproven and failing programs, and yet it is neglecting basic city services and functions like having a full-time RN in every public school. The failure of our city to address the downward spiral of RN staffing in our health suites is putting our students at increasing risk if they experience a medical emergency without an RN on site. Upon its formal introduction and referral to the Committee on Health, I request Chairperson Henderson that you please hold a hearing on the Universal Full-Time Public School Nurse Requirement Amendment Act of 2024 and fund this legislation in the fiscal year 26 budget and corresponding financial plan. That includes my written testimony for today, Chairperson Henderson. I am pleased to answer any questions that you or your council colleagues have for me. Thank you very much for allowing me to testify.
Thank you, Mr. Goulet. I don't have any questions for you specifically, Chairman Mendelson. The chairman does have some questions.
Thank you, Mr. Goulet, for your testimony. First of all, so there's been a lot of discussion at this hearing about this bill, but I don't think I've seen it. So when are we going to get it?
So the State Board staff, I think, has transmitted it through the Office of the Secretary. I've attached it to my testimony.
Yes, I saw.
This morning.
It's attached with letterhead. I trust it's not going to come over for introduction with letterhead.
No, sir. We'll make sure we comply with all of the council requirements with that.
So I take from what you're saying shortly.
Yes, I thought our staff at the State Board of Ed had transmitted it already. So I believe they're working with the council secretary. As you're aware, I think we've introduced one piece of legislation throughout our relatively brief history. So this will be bill number 2. So I think they're working to just make sure that they get it right as they submit it.
In your statement, you said DC must increase grant funding provided to Children's School Services based on testimony in January will require an increase of roughly $7.5 million per year for each of the next 4 fiscal years. Is that a $7.5 million increase, or is that 7.5 million next year, an additional 7.5 million the following year, meaning 15 million, an additional 7.5 the following?
Your latter reading is correct, Chairman Mendelson. The Councilmember Henderson asked what it would take, and they estimated roughly $30 million to be able to get ourselves to full nurse staffing. So what that figure entails there is an assumption that it will take time to staff up, that you won't be able to do it in just a single fiscal year. So it's assuming 7.5, incrementally, then 15, then 7.5, and then finally the final 30 at the end. Now that's all going to be subject to revision, obviously, as we get the final number, but we were hoping to get that number before the fiscal year 26 budget process starts, so we can come back to you with a firm number on what the cost would be.
Okay, so it's easy enough to say that we want an RN in every school. But my understanding is that there's a shortage of RNs. And while I can't say I'm a fan of the cluster model, and I'm not advocating that here, what do we do? What's your answer to the shortage?
Well, I think we need to pay a competitive rate. Prince George's County just increased the amount that they pay their nurses. We're not competitive in the region in terms of our salary. And the cluster model is also making it harder to retain nurses because it's removing the intangible benefit of the job that brings many of those nurses into the profession, which is attachment to the school community and the students at the schools. So we're removing the intangible that keeps them there because they love the profession, while at the same time not paying them a competitive rate of salary and benefits to compete with not just other schools in the area, but other hospitals. I mean, we at UMC compete for nurses with the other hospitals and then with the schools here. And it's important that if we're going to be able to have a full complement of school nurses, we need to pay them a competitive wage for the region.
So I did want to ask you this. You said the cluster model is causing nurses, RNs, to flee school nursing. And your answer, and when I say, how can you say that, or why is that? Your answer is because nurses like to be assigned to a single school rather than this cluster approach?
Yeah, from some of the nurses I've spoken with who came to testify to SBOE and others who've written me, I mean, one thing they mentioned is basically being treated as, on-call EMS versus somebody who builds relationships with their students. And the reason they got into nursing with the school community is to serve that community. And it hurts both the students, and then it also causes the nurses to leave because all of that reward that's usually there is removed in the cluster model. And they're basically just trying to do telehealth to cover for LPNs and health practitioners that can't independently diagnose issues for students.
And you're basing that on testimony at the board, as well as conversations, as well as just personal observations?
Yeah, and the number just dramatically falling. As we've ramped up the cluster model, this was a concern we had back, when I was the Committee on Health staff director, that we were losing nurses this way, that people were saying that back then. But as the cluster model has been more heavily used, the number of nurses fleeing has also increased. They're getting out of a system that doesn't allow them to serve schools, instead just reacting to emergencies. So I think the more we use the cluster model, the more of our nurses will leave us, and the harder it will be to retain those that are still here.
Thank you. I don't have any other questions. Thank you for your testimony.
Thank you, Chairman. I appreciate it.
Thank you. So as I said earlier, I'm going to change it. We're going to take a 6-minute break, but I do want to just sort of state 2 things. And perhaps maybe DC Health or Children's School Services should have labeled this differently as opposed to a health tech. I don't want someone to assume that a health tech has absolutely no training. In fact, many of our health techs are EMTs, which means when you call 911 and EMS comes, you're getting an EMT who has been trained in the same manner as a health tech. And perhaps because we are calling it something different. I don't want to demean the work that these individuals do, nor their education level. The same with an LPN, a licensed practical nurse. They are licensed by the Department of Health. They go to school and they are trained in nursing. LPNs are a great career ladder pathway in the nursing profession. And so I don't want folks to assume that an LPN is somehow less than qualified to be able to provide care and service in a school health suite or to our students, because LPNs serve residents and care settings each and every day, and nursing homes and other settings as well. So I don't want, in the policy disagreements, I don't want us to degrade someone's educational experience because the title doesn't seem as prestigious as being a registered nurse or an MD. And with that, we're going to take a 6-minute break, and then we'll be back to hear, we'll hear first from Terry Thompson, who's the director of SHPTA, and then we'll hear from Robin Dix-Purdue, who's the Senior Deputy Director of the Community Health Administration at DC Health. Thank you. All right, and we are back. I'm now calling the government witness for Bill 25-948, the Certificate of Need Improvement Act of 2024, Terry Thompson, who is the Director of the State Health Planning and Development Agency at DC Health. Before I begin, Terry, I need to swear you under oath, or anyone from your team who might join you. There we go. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Please begin.
Thank you. Good morning, Chairwoman Henderson, council members, and Committee on Health staff. My name is Terry Thompson, and I am the Director of the State Health Planning and Development Agency, also known as SHPTA, which is within the Department of Health. On behalf of Dr. Ayanna Bennett, Director of DC Health, I am here to provide testimony on the Certificate of Need Improvement Act of 2024. This legislation makes changes to the requirements for obtaining a certificate of need from the SHPTA. While we support the intent of this legislation, we have several recommendations to further strengthen and improve its impact on our health system. The district CON process plays a significant role in ensuring that healthcare resources are allocated efficiently and equitably, and that health services are accessible to residents across all 8 wards. CONs serve as an important regulatory tool to manage the development of healthcare facilities and services, including establishing new hospitals, making major capital expenditures, and establishing and relocating as existing health services. The CON process also ensures that new and expanded health facilities are necessary, cost-effective, and avoid unnecessary duplication of services. This process helps manage the distribution, accessibility, and types of healthcare services across the district, guiding decisions on where hospitals, clinics, or special care centers are developed to maximize accessibility. Since its inception in the mid-1990s, the Certificate of Need process has ensured a well-balanced and efficient healthcare system by evaluating the necessity, quality, cost-effectiveness, and potential impact on new projects and expansions. Through a dedicated team of health system planners, approximately 130 CONs have been issued since January of 2020, ensuring that healthcare needs are met while avoiding inefficiencies in service delivery. DC Health is committed to maintaining a modern CON process by addressing population health needs and adapting to the evolving landscape of healthcare technology. DC Health supports several provisions within this legislation, but also recommends adjustments that will further modernize the CON process. The proposed biannual updates to capital expenditure thresholds aim to keep the process relevant to current economic conditions. However, rather than using a fixed dollar amount as a threshold for certificate of need review, SHPTA recommends that the CON process be initiated when a covered entity seeks to expand a certain percentage of their revenues. This adjustment would ensure that large and small healthcare facilities of the same type are not subject to the same threshold, given the vastly different financial implications. This alternative would create a more equitable process reflecting the financial realities of different healthcare providers. Percentage-based expenditure models have been explored or implemented in other jurisdictions, including Tennessee and New York, to address disparities in healthcare facility size and revenue. Unlike a fixed dollar amount, this model would ensure investments are being evaluated in a manner that better serves the district's diverse healthcare landscape. The bill would also exempt non-patient care projects from certificate of need review. While DC Health agrees with the definition and exemption, we recommend that large-scale patient care projects still trigger a notification to the SHPTA without requiring a full review. Although these projects do not directly involve patient care, they can have significant impact to the overall healthcare system. Requiring notification would promote transparency and encourage thoughtful investment decisions that align with broader healthcare goals. Without such safeguards, there is a risk of large-scale expenditure being allocated inefficiently. Similarly, DC Health also recommends that non-patient care projects be aligned with a percentage of revenue to account for differences in facility size. This alternative approach will promote more deliberate investment decisions and strengthen the district's overall healthcare infrastructure. DC Health supports the inclusion of a definition for group practice, as this clarification will help define the scope and responsibilities of these practices within the CON process. As healthcare increasingly shifts towards integrated care models, it is important to define and regulate group practices in a manner that promotes both collaboration and accountability. Further, the legislation exempts primary care and specialty care providers from the CON review process. However, it currently lacks specific definitions for these provider types. Given this limitation, DC Health recommends adjusting the language to reflect a change in the definition of healthcare facility. Currently, the definition includes ambulatory care centers or clinics, which encompasses primary and specialty care providers. DC Health proposes removing the term ambulatory care center or clinic from the healthcare facility definition and replacing it with freestanding emergency room and urgent care facility. This change would still exempt primary and specialty care providers from the certificate of need review by omission, eliminating the need for specific definitions for each term. As a result, the CON process would be clearer while still allowing DC Health to focus on large, more complex facilities that have a broader impact on the healthcare system. Finally, DC Health supports the creation of a registration process for exempt entities, including ambulatory care centers and clinics, as well as virtual provider networks and telehealth platforms. As the telehealth market continues to grow, presenting new opportunities for healthcare access in healthcare shortage areas, the proposed registration process will provide necessary protections for our most vulnerable residents. DC Health supports this exemption and will ensure that the registration process includes appropriate safeguards to maintain quality care. While telehealth is transforming how care is delivered without proper regulation, there is a risk that these services may not be provided with the same rigor as in-person care. DC Health looks forward to balancing CON exemptions with registration requirements that will ensure that telehealth services and ambulatory care remain both accessible and high quality. DC Health remains committed to enhancing and modernizing the CON process to adapt to the evolving healthcare landscape and new technologies, such as telehealth. We are continuously collaborating with our partners to ensure the process meets the current and future needs of district residents. Our vision for a modernized CON process includes streamlining operations, improving equity, and enhancing regulatory safeguards to protect public health while facilitating necessary growth in healthcare services. DC Health appreciates the opportunity to provide feedback on the Certificate of Need Improvement Act of 2024. This legislation offers an opportunity to modernize our Certificate of Need process in ways that will reduce barriers to expanding healthcare services in the district while continuing to safeguard our residents. However, we strongly encourage the committee to accept our recommendations to strengthen the bill, particularly around the notification of non-patient care projects, the definition of key healthcare services, and safeguards for telehealth. We look forward to continuing our collaboration with the council to ensure that our healthcare system remains responsive, equitable, and equipped to meet the evolving needs of district residents. Thank you, and I am available for any questions you may have.
Thank you so much, Ms. Thompson. We'll do a 10-minute round. We'll see if my colleagues join, but let's just, thank you, Mr. Chairman. He just yielded me his 10, so give me 20. But I'm gonna have more than that, because as you know, Director Thompson, the CON process is sticky. It could be technical in nature, and so there are some things that we just want to get it right. So I want to get some things on the record. Earlier this morning, we had testimony from some witnesses who suggested that substance use disorder services, as well as inpatient psychiatric facilities, be exempt from the CON process. I'd mentioned that and learned from the Department of Behavioral Health that in August, SHPTA decided to waive the CON process for SUD, substance use disorder, providers or facilities. Can I ask, what was the impetus of making that change?
So the way that the law is written currently, any service that is under the exclusive jurisdiction of DBH is not subject to certificate of need review. There was a conversation, there have been a series of conversations with DBH about service providers that they believe fall within that that definition of exclusive jurisdiction. And so that's why there were two providers, I believe, that they believe fall within their exclusive jurisdiction, and we defer to them on that definition.
Okay. So I'm glad we sort of came to this, but I guess just for clarification, so is it current law, or I guess current practice, that any care that is provided under the jurisdiction of the Department of Behavioral Health exclusively is not subject to CON?
So that's always been the law. So what hasn't been consistent is having conversations with DBH about who those providers are specifically. And because of a host of concerns about access to care with DBH, we've been having those conversations.
Okay, that's good that the conversations are ongoing. I guess I express this frustration with DBH in that I have providers who, as you know, went through the entire CON process with you.
Yes.
And no one at DBH ever said, hey, you don't need to do this. So they not wasted, but spent a lot of time and a lot of money to go through that process, and then to come to find out like, oh, actually, you didn't need to do that at all. And that's the frustrating part for me because, I think as you know, and as everyone I feel like in the health space knows, particularly on our behavioral health side with SUD, and otherwise, as we were going through are still going through an opioid crisis, this should have been a priority and stated 2 years ago when we were losing 600 people to opioid overdoses, fatalities. So that's good to hear. So do you feel like there needs to be a clarification here that doesn't allow for the provider by provider exception?
So yes, there probably is some form of a codification that would be helpful for the broader community to have clarity.
Okay.
And so I would be more than happy to work with the council along with DBH to make sure that we are clear about who's in and who's out.
Okay, all right. So in your testimony, you mentioned SHPTA has issued 130 CONs since January of 2020. Is this just the number that has been approved, or is this the total number of applications that you all have received?
I believe it's the number that has been approved.
All right. Is it possible we could get a follow-up from you,
Yes.
from your office around a breakout of what that 130
Absolutely.
fits in? So how many of those were new facilities? How many of those was a capital expenditure change? How many of them were a change of ownership, et cetera? We're just trying to get a better understanding of you know, what the field represents.
Yes.
Okay, great. The state health systems plan is supposed to be the guiding document for SHPTA in determining the public health or the public need for health services. The plan was last updated in 2017. What's 2025 is around the corner. It's like waving at us. So what's our plan?
So we are running up to the finish line on this document. You
Okay.
are correct. It is the roadmap. And so our expectation is to have it across the finish line before the end of the calendar year.
Okay.
It is, as right now, the title is the Health Systems Plan of 2024.
Okay. Does this require a public comment or some approval by the executive over here?
So it does, all published documents have a review process by the executive.
Okay.
And there is a publication requirement that's in the statute. And so we just want to make sure that we are consistent with the statute, and I need to work with the general counsel's office to make sure of whether or not it's a resolution or if it's just simply publication in the register, because I do know that we're coming to the end of the council period. And I do not want the document showing up at your doorstep, council member and chairman woman, to then have it have to be reintroduced in January.
That's right.
Yes,
Brand new when we're done.
I understand.
what's the
Signy
last
die
day?
is signy die.
December 17th.
Yes.
And it's a wrap. No. So we've I think that's important, and I want to get that over the finish line. I was asking
Yes.
about the executive review because I have this ongoing list with the city administrator, as well as an ongoing joke where I ask him about all of these reports that everybody claims is sitting in his office. And so I always like.
Well,
to-
this is not in their office yet.
Okay, great.
And so it's not.
We've heard from many witnesses today about the length of time that it takes to complete a CON. And I think even for me, the idea of like 6 to 9 months or even longer, depending on whatever the particular project is. Let me ask you this. How many staff do you have reviewing CON?
So there's a total of 5 of us.
Total of 5.
There are 3 analysts, myself, and we have an administrative staff.
Okay. Is 6 to 9 months an average?
Probably not. So it's not 6 to 9 isn't an average. 6 may be close to the average, but let me explain the process a little bit.
Okay.
So the certificate of need process starts with a letter of intent. So it's to give the SHPTA and the public notice of what's coming down the line. So for sake of the conversation, the freestanding emergency department over on Ward 7, we got notice through the LOI and publication in the newspaper. There is then a 60-day period during which we have conversation. So they call it a waiting period, but it's really an active period. So the public starts asking questions about, hey, what is this? And we encourage members of the public who are curious to contact the applicant, and the applicant has conversations with the SHPTA about what needs to be in the application itself. Many applicants actually come to us in advance. We have the ability to waive the 60-day period and have done so for services for which there's a need to expedite the process.
Okay.
So The difference between 6 months and 9 months or a year or longer is the difference between what happens from the day that that letter of intent comes to us and when we get the certificate of need application.
I see.
So the
Okay.
certificate of need application review period is 90 days unless the applicant asks for additional time, which happens from time to time, right? So we'll get an application. There will be questions that are asked. And in order to give the applicant sufficient time to answer those questions, they may ask for it to be delayed.
Okay. On that, so some other states do expedited 30-day review for a CON application when they have identified that the particular service is a high need.
Correct.
Does
And
SHPTA
the
have a
district
similar?
has the authority to do that.
Okay.
Generally speaking, that authority goes with services that are identified in the health systems plan. Our prior plan had not listed any services that should be expedited.
Okay.
So we're being very thoughtful in this planning period about services that may need expedited review. But the SHPTA also has the ability to advance projects once the application is complete. There are no further questions. And so we have, in fact, moved applications faster than the normal process because we've gotten applications that were complete upon arrival because the applicant had worked with SHPTA all the way up to the date of filing.
Okay.
So then we move the review date for the project review committee and SHIC forward. So one of the things I did when I first got here, it used to be that the meetings of the statewide health coordinating council came first on the schedule, and then the project review committee met after the SHIC. I flipped them so that if we review application that is ready to go, the project review committee signs off on it, everybody's happy about the service coming, it can go straight to the SHIC. So the other way, we had 30 days between one meeting and the next meeting in order to get SHIC review and recommendation.
Okay.
So we've shortened it by 30 days already.
Okay.
There are times when even with the recommendation still has some questions that need answering. And so we will have the applicant resolve those issues as we are in the process of drafting the certificate of need determination. So we don't dilly-dally.
Okay.
That's a technical term.
Let me pause for a minute. Councilmember Parker, Chairman Mendelson gave me his 10 minutes, which is why I had 20 on the clock. I didn't know if you actually had some questions for Director Thompson. I didn't want to monopolize the conversation. You're on mute.
I have no questions now. I'm waiting for DC Health.
Okay. All right. Then I will continue on. Okay. Director, in your testimony, you proposed continuing to require the CON for non-patient care projects over a certain expenditure threshold. Again, proposing that it be a percentage of the entity's revenue. If the purpose of the CON is to ensure equitable distribution of healthcare, why is the review of non-patient care projects necessary?
So we're not asking for review. So what we're asking for is notice of them so that we can, so what we want to do is to make sure that our facilities are keeping track with their schedules for maintenance and for replacement of equipment and to know what's going on in those facilities. Oftentimes, it means that parts of the facility have to be taken offline. We've had hospitals that needed to replace their MRIs, which then meant that they had to move to a temporary MRI in a trailer for a while, which is fine. But kind of knowing what the landscape is looking like from day to day is helpful to us ensuring that we have a health system that is able to meet whatever the wind or weather or the rest of life causes.
But is that a little bit duplicative if I am, like, so for instance, let's see, non-patient care project. I don't know, what's an example of an outpatient?
So if we're getting a new HVAC system in a hospital, knowing that someone is going to be taking parts of their system offline,
right,
is helpful to the entire system.
Right, but what do you do
what
with-
we're asking for is notice from, so right now, we get notice from providers of services or non patient care expenditures. It comes in the form of a letter. We may have a question or two about how they're going to maintain services while making that change. And then that's the end of notice. It's not a review. And in fact, with capital expenditures, we've moved more to a notice way of handling that application. So we're not looking for an elaborate explanation of need. We really are trying to make sure that the services are going to be available. And if there is going to be a reduction in service while these changes are happening, that we know what that's going to look like so that we can prepare for the rest of the system.
Are you sharing that information out? So like, let's say if it's an HVAC situation, I mean, the other entity of DC government who would know that would be Department of Buildings, because somebody would have had to pull a permit in order to be able to do that. But if it is gonna then require certain pieces, I mean, I guess I'm just trying to get to like sort of the duplicative nature in terms of notice, because if I'm a hospital that's doing an HVAC project that's gonna take a particular clinic offline, I will have already had to have notified several parts of the government, no?
We would hope that that's true. So part of what happens is when permits are pulled, they may be pulled in the name of the contractor, not in the name of the facility. Or they may be a facility that's name doesn't represent that it's a healthcare provider. So what we have started doing is making sure that our colleagues over at, I'm going to get the name wrong, the Department of Buildings, that they get a copy. So we copy our sibling agencies to make sure that other agencies are aware. And my conversations with the Department of Buildings staff is that they weren't necessarily aware of a facility being a healthcare facility. So when they're looking at it, they may believe that it's, you know, just an office building.
Okay.
Right? Because that's how it's being referenced, as it's an office renovation. And in fact, it is an office renovation, but it's a healthcare office.
Okay. The bill proposes to exempt telehealth companies from the CON process, but would create a registration process for them. Do you have any concerns from a state health planning perspective about exempting these companies?
So there are a cadre of facilities that I think probably should not have to get a certificate of need because of the services that they're providing. And then there is the rest of healthcare that I think we need to at least be clear about. So not knowing who's coming in. So I think the registration process will be really helpful so that we are clear about who's coming and who's providing services to the district residents. I heard your question earlier today about a provider, a physician, and their license being on the line. The challenge is that the patient has to know and remember Dr. Smith, as opposed to they know that they went to telehealth ABC to get care. And if there's nothing to register or hold telehealth ABC accountable, then you have to track back to the physician to figure out whether or not the medicine that they provided actually is violative of their oath, which is because, as we've talked about before, malpractice is a civil action. It's not necessarily violative of the requirements of the board.
Okay. The bill exempts primary care and specialty care practices. Although primary care appears to already be exempt in DC code, we've heard frequently from facilities that they're being told they need a CON before opening or expanding. Can you explain what's happening there?
So the person that testified in that manner wasn't able to give an example, so I'm not sure.
Okay.
We have had providers that wanted to expand their services. So we've had ambulatory surgery providers who wanted to add additional suites to their practice, and they were required to get a certificate of need. And I don't believe this legislation would change that.
Okay. So DC Health has expressed some concerns about the metrics currently required by the DC code to measure spending thresholds that trigger a CON. Can you explain your concerns and which metrics you believe would be more appropriate?
So currently the metric is just a flat dollar amount that applies to all healthcare providers of that type. So for all hospitals, it's a set number, and not all hospitals have the same level of operating expense or revenues. And so the idea of using a percentage rather than using just a fixed number is to make sure that you're not penalizing smaller facilities or facilities that have a lesser revenue stream, and that we are also making sure that their revenues can cover all of the expense that they're intending to.
Okay. Does SHPTA currently require a CON if a facility is replacing one machine with another?
So we do not. We usually get notice so we ask that providers let us know as they're replacing, because it then replaces the prior equipment on their CON. So we keep track of those things.
Okay. For major medical equipment, are you concerned that setting a monetary threshold could incentivize facilities to purchase less effective equipment? So for instance, if a threshold is 5 million, and then we now have all of these companies who are offering something at like 409, like 4.95. Like,
I know, and
we see this happen well, not all the time, but we do see this happen, particularly with contracts over $1 million, where like the contract will come in right under, just to exempt from the process.
So the law requires it to be, so they're supposed to tell us what they're paying for it. They're also supposed to tell us what its fair market value is, because sometimes so for example, there may be discounts that are being provided, to your point, by the vendor that brings that number down.
Yeah.
So when we look at it, we're looking at what they're paying plus the discount, right? So what the fair market value is.
Okay. How long does a review take of a CON that's specifically related to medical equipment?
So that they are fast tracked, because usually when somebody's ready to purchase new equipment to replace old equipment, it's something that they want to do now, or it may be something that needs to be replaced right now. So that's something that moves in a matter of days. It depends on whether or not the provider actually gives us just, the plain information of what it is and what the expenditure is.
What if it's not a replacement? So for instance, there's a new machine on the market that allows for providers to be able to do tests for preeclampsia via like a blood test. It's brand new. If there was if MedStar Georgetown wanted to purchase this, they would have to go get a CON?
So let me say, if it meets the threshold, they may, but we would use the notice type of, so we use something that's more akin to the notice, unless it creates a new service.
Okay.
And that doesn't sound like that example doesn't sound like a new service. So they would send us a letter saying, hi, we're looking to purchase this equipment, and we would respond in kind.
Okay, I only have a few more. So the hospitals have requested that the definition of uncompensated care be expanded to not just include charity care, but BAT or debt coverage for district residents as well as non-district residents. They argue that they also must take patients from Maryland and Virginia, where there could be a higher uninsured population. Well, they have a higher uninsured population than we do, as well as travelers from other states and globally. What's your reaction to this?
So I welcome the opportunity to have a conversation about uncompensated care. I actually don't believe that there's a need to make a change to the statute in order to make the types of changes that I've heard in the rumor mill to uncompensated care.
Okay. What types of guidelines or requirements does SHPTA currently have for corporate practice of medicine? So for instance, I'll use the example because it exists, right? So Amazon purchased One Medical.
Yes.
Who gets to set the standard of care? Does Amazon
So
do it, or
when Amazon subsidiary purchased One Medical, then Amazon took responsibility for the certificate of need and the conditions that apply to the certificate of need. So when we do a change of ownership, one of the things that we're asking for is whoever the new owner is to take the responsibilities that the prior owner had.
Okay, so it doesn't start fresh.
No.
Okay. FQHCs already qualify for a lower CON application fee in the current law, but some have suggested that they should be completely exempt. What's your reaction to that?
So if primary care and specialty care facilities are exempt,
Most
I'm not sure
FQHCs
that
are.
they would be required to get a certificate of need either.
Got it. Okay, I'll ask this question. It's a transparency related question. And I've had the similar question with other agencies about this as well. If, let's say I'm a provider out of state and I'm thinking, DC might look like an interesting market. How would they find information about what our CON process is? Is this available? Like, could I go to the website and just like look what the checklist is, or would I have to call and get an appointment?
So we encourage both. So we do have a website that has all of the information on it. We're working on updating our website. We also have what is known as board docs, which is where all of our meeting information is and the applications that come before the SHIC. And so there are applicants that are curious to see what other providers have asked for and what the process has looked like. And so we've encouraged those providers to go through some of our other available information. And then, of course, we always open our doors, or at least our cameras, to meetings to have a conversation about what the certificate of need process is and how to move through.
Okay, give me just a second. All right. Let me ask, oh, no, okay, he doesn't have. Let me ask Councilmember Parker, do you have any questions for Director Thompson? Okay, great. All right, well, we're done.
Thank you, ma'am.
Thank you so much. If we could just get that information about the breakdown of the CONs that have been approved since 2020. And then we'll certainly follow up with you as we sort of work through this process, you and your team. But thank you so much for being here today.
Thank you.
Thank you. All right, so we're going to move to the government witness for Bill 25-0690, the Public School Health Services Amendment Act. We have Robin Diggs Purdue here, who is the Senior Deputy Director for the for the Community Health Administration. at DC Health. And before you begin, Deputy Director, if you could raise your right hand. And anyone else who might join you, I don't know who might join you here, but do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and the Committee on Health is the truth, the whole truth, and nothing but the truth? Great. All right, you turn on your mic and you can begin.
Right. Good morning, Chairperson Henderson, council members, and staff of the Committee on Health. My name is Robin Diggs Purdue, and I am the Senior Deputy Director for the Community Health Administration at DC Health. On behalf of Dr. Ayanna Bennett, Director of DC Health, I am pleased to offer testimony on the Public School Health Service Amendment Act of 2024. DC Health supports the intent of the legislation to strengthen school health services for District of Columbia students and looks forward to continued collaboration in this area. Through a partnership with Children's School Services, DC Health School Health Services program supports over 83,000 students across District of Columbia public schools and public charter schools in all 8 wards. DC Health School Health Services program operates 185 health suites across 214 public and public charter schools. As of October 2024, the program is supported by 198 health professionals, including 32 licensed practical nurses, 44 registered nurses, and 122 health techs. These professionals provide first aid to students who are injured or ill, help manage chronic conditions, administer medications, and support care coordination and immunization compliance, and conduct vision and hearing screenings. The district, like all jurisdictions across the country, is experiencing a nursing shortage. A 2022 survey from the National Council of State Boards of Nursing and State Nursing Workforce Centers estimated that by 2030, there will be a deficit of nearly 1 million nurses nationally. DC Health and its partners altered its care model to fully staff the program in response to this national shortage. As this council has heard, the School Health Services program uses a cluster model of teams of at least 2 nurses and 2 health technicians for each cluster of schools. This cluster model allows all schools in the program to receive in-person staffing. This in-person staffing is foundational to the program, as research has shown that access to health services at school improves health outcomes for conditions such as asthma and diabetes. Despite workforce challenges, approximately 98% of the health suites in the program currently have a 40-hour-a-week in-person staff member assigned, which is a drastic improvement from previous years. DC Health is currently providing more school nursing coverage than legally required and is constantly striving to find ways to improve the quality of health services provided to students in the district. School health suites operated by DC Health also offer telehealth services to students at participating schools. The program allows for students to be seen in real time by a provider in non-emergency situations. During visits, students can be assessed, have a treatment plan developed, and have medication delivered directly to the school and be returned to class or sent home if necessary. The Public School Health Services Amendment Act of 2024, which strengthened health services for students in the district schools by mandating all public and public charter schools have at least 30 hours of nursing coverage, regardless of their participation in DC Health School Health Services program. The legislation allows for the coverage to be a combination of a licensed practical nurse or other qualified health professionals, which is defined as people who complete accredited training programs and are certain types of health professionals, including physicians and physician assistants. The legislation establishes a deadline of October 31st in the previous school year for schools to request nursing services for the following school year. Finally, the bill expands DC Health's current scope of support by mandating the agency provide technical assistance to schools that are not in the School Health Services program, and that DC Health collect and publish data on school nursing coverage. DC Health would like to commend the council for their efforts to strengthen school health services access by mandating adequate levels of school nursing coverage at all public and public charter schools. The bill helps clarify DC Health's ability to use a cluster-based model to deliver school nursing services, which ensures students have access to quality care while still recognizing the current realities of the workforce. While appreciative of the intent of the bill, DC Health has concerns with some of the provisions as currently written. First, the definition of health professionals in this legislation should be aligned with the programmatic intent of DC Health's School Health Services program. Aside from registered nurses or licensed practical nurses, this bill restricts who else can work in a school's health suite. As currently implemented, a cluster model relies on other health professionals to play an essential role in supporting the health and wellness of district students. Therefore, to ensure continued competence among school health suite personnel, DC Health recommends that health professionals be licensed, registered, or certified by the department under the Board of Medicine, Board of Nursing, or as determined by the Director of DC Health. This will ensure that health professionals are adequately trained to address school health needs and can be held accountable for standards of care. The legislation also does not define public and public charter schools, which leads to the inclusion of schools that primarily serve adults. The School Health Services program does not cover adult serving schools, of which there is a robust network of campuses serving hundreds of district adult students, as adult learners are able to take care of their own medical needs and leave campus to seek medical help if needed. DC Health would ask that the legislation be written to specifically exclude adult serving schools from this coverage mandate in keeping with current practice. It is also imperative that basic standards of safety and quality are required for schools that are not part of the DC Health School Health Services program. DC Health staff routinely conduct site visits to participating schools to ensure quality and safety standards. For example, a school nurse or health technician may need to provide a student with a medication that needs to be refrigerated or kept in a secure location. DC Health would verify this standard was met prior to opening a new health suite and during a school inspection. School inspections and other compliance actions ensure that students who receive school health services through DC Health will have access to safe and high-quality services. Appropriate safety standards should be met for schools that choose to independently house their own school nursing services. DC Health appreciates the efforts to define a timeline for requests for new school health suites. While we do not have any concerns with this timeline of October 31st of the previous school year, it should be noted that requests will only be approved contingent on compliance with School Health Services program standards and available funding. In summary, DC Health supports requiring district public and public charter schools having 30 hours of school nurse coverage, even if they are not part of our program. However, DC Health does suggest a few changes as outlined in our testimony to maximize school health efficacy across the district. We appreciate the opportunity to discuss the importance of providing quality services to our district students. Thank you for providing me with the opportunity to testify, and I'm available to respond to any questions the committee may have. Thank you.
Thank you. We're going to do 10-minute rounds. We've also been joined by Councilmember Matt Freeman, who's a council member from Ward 3. So I'll do my best to stick within my time, and we'll sort of pass it on from there. Deputy Director, thank you so much for your testimony, and also for the ongoing collaboration that we have had over the past 2 years as we try to improve overall school health coverage and all the other things that are under CHA as well. So, last year we had heard reports of schools where they were listed as having full-time coverage, but the assigned staff was calling out several times per week, which was leaving suites empty. How has DC Health in partnership with Children's School Services improved on this system this school year?
So last year, we also had a high percentage of contract nursing staff. And so we worked with CSS to ensure that there were actual FTEs hired to provide the service to help support consistency across the health suites.
Okay. And I'm not sure if you caught my comments at the end right before we went to break around how I think it is healthy for us to have criticisms and talk about the need to improve the program. I do not feel like it is healthy for us to demean individuals who are serving as health techs or LPNs because they are not registered nurses, even though they have had trainings. As I mentioned, you know, many of our health techs are EMTs. And so if you called 911, you would get an EMT. When I think all of our firefighters are also EMTs as well. So they are able to provide a level of service here. Can you speak to a little bit of the training pieces in terms of, you know, why the public health agency felt comfortable not having just a registered nurse and a health suite, but the full complement of health professionals who can provide this service?
Sure, and we do have 8 nurse managers that are part of the program, and so unlicensed health professionals are allowed to be delegated duties by an RN if the RN feels that they are competent to do so. And those can be duties outside of their regular scope, but actually within the scope of an RN. So we do have several health techs that have a background as a certified nursing assistant or as an EMT or have other certifications. While they're not working under those particular licenses while they're a health tech, they do have that background in training. They also undergo training through CSS, and there are consistent professional development opportunities that happen throughout the year. One of the benefits of also having the requirement of 30 hours is for nursing coverage is that it will allow more time for additional professional development as well as operational meetings that can support continuous quality improvement.
Okay. Well, let's just let's play a hypothetical. Let's say the mayor says, nope, DC Health, we want to register RN in every school. And she says, I'm going to provide you with the $30 to $35 million in the budget to be able to do that. Do you feel like you or our current grantee or a future contractor or grantee would be able to deliver 100% coverage?
I think it would be very challenging, and it would certainly not be something that would happen right away. Our hospitals, our urgent care centers, our doctors' offices also are experiencing the nursing shortage, and we need to have nurses there, especially in settings where people go specifically to keep them alive. So we don't want to pull from that pool. The other challenge is that for nursing students, school nursing is not typically the first choice, right? After school, right? People want to work in a setting where they are going to be able to regularly utilize the skills that they've been trained on.
Operate at the top of their license.
Exactly. So it's not just a money situation. It is also that larger workforce issue. But I do think that there are opportunities to increase the numbers from where they are now. But
so let's talk about that. We heard testimony earlier that I guess the number of full-time nurses that we have is like half of what we had the previous school year. Can you give some additional data context here?
Right, so we have 44 RNs hired right now, 32 LPNs, and 122 health techs. For our RNs, our goal for this year is to get to 47 RNs and 54 LPNs and 143 health techs.
Okay.
Currently, we are at 81% of our target overall for hiring.
Okay. One of the things we also talked about earlier this year was the need for us to do essentially like a salary analysis, because we know, I think it was PG County up their amount in terms of for full-time nurses. I think Montgomery County may have made an adjustment. Have we done this analysis to determine if we are competitive?
Yes, so PG County did increase their salaries last year and again this year. So they are
Okay, so they are responding to demand.
yes, but it's deeper than that as well. So
Okay.
they also are hired by the health department. And I think in Virginia, they're hired by the educational system. So they are government employees. They work a 10-month schedule similar to teachers.
Interesting.
Where they have government benefits and can choose to get paid across that 10-month period or across a whole 12-month period. Yes.
Okay.
And again, other benefits, government benefits that, CSS doesn't necessarily have.
Right. I mean, I think that's even Ona and I were sort of discussing, right? Like, even if we said, oh, the average salary is 110,000, then you need to add whatever fringes for that, because I'm imagining there's some benefits that are sort of associated in that realm.
Mm-hmm.
But that being put to the side, even though we know that they're being considered true on government employees, again, minus the benefits, on the salary side, are we competitive? And have we done this analysis, and do you all have that information?
Yes, they have increased salaries on the CSS side as well. I'd say PG County is still a little bit higher.
Are we paying the less? Are we the last on the list of like our 5 surrounding school districts? Are we the least competitive?
We're probably still under both Maryland and Virginia.
By how much?
I'll get back to you on that.
Okay. I want to see the breakout.
Yeah.
Because we talked about this at the beginning of the year, needing to do this analysis, and I think it's important.
I do have it. I'm just not remembering.
And I know that you guys have it. It's important in terms of when we have these budgetary conversations about us needing to remain competitive, and whether it be in health or otherwise, right? Even in the government or policy space, I got to compete with the federal government. So it's important for me to know how much they're charging for attorneys, so that the Office of the Attorney General or the Public Defender Service or whatever is able to be able to properly recruit.
And I don't think we're way off in terms of the average, but again, I think some of the other benefits.
But hey, look, we do this in terms of school bus drivers. We had to increase our salaries to compete because, you have a CDL, you can basically go anywhere. And so I think this is important that we do this sort of periodic update.
Yes.
Now, recognizing we can't all raise, if everybody's raising and raising, and then like, where do we, there are limitations to what we do. But if we're off by 10 grand, that's significant. If we're off by 2 grand, that's all right, negligible. We could kind of figure some of those pieces out. Ever since I've been in DC, I think that the school health program we have either contracted or granted it out. Has there ever been a time where DC Health has managed this, or DC Public Schools has managed it in-house?
Not to my knowledge. It might have been before DC Health actually became DC Health, like when there was some type of commission or something like that. But since we've actually been DC Health, no, it has been either granted or contracted out.
Okay. I am over my time. Councilmember Parker is on the screen.
Thank you. And it's good to see you again, Deputy Director.
Yes, good to see
My
you.
First question, your testimony noted that we'll likely have a nurse deficit of nearly 1 million by 2030. What is DC Health doing to not only strengthen the school health services program, but ensure adequate coverage for a wide range of health needs in the district between now and that date?
So DC Health does have several initiatives focused right now on our healthcare workforce. We also have a high needs scholarship program. We have our loan repayment programs, but the boards as well are focused on this issue and trying to look at data and come up with solutions to plan ahead to address that shortfall for the future.
And the loan repayment program that is specific for nurses, I know that was elevated in certain testimonies, especially from the State Board of Education. Can you just speak more about what current practice we have in place around loan repayment?
Yeah, so we do have a health professionals loan repayment program, and nurses are eligible for that program. Thus far, though, most of the nurses in that program really focused on substance use disorder and are meeting that particular workforce need. And we have, limited amount of funds to use for that program, but that is a program that we do have.
Understood. The point there is we don't need to recreate the wheel. It's clear you are already doing the work. It may be best that this committee explores how we might scale that program or deepen its impact. Also, something that came up, at least from one of the State Board of Education reps, was this legislation that will mandate a nurse in every school in the district by 2028. Is that possible, just given the numbers and the deficits that we're currently seeing?
I still think that might be unrealistic, again, because the first priority would make sure that we have the nursing staff that we need in our hospitals and urgent care centers. But like I was saying earlier, I do think that there are opportunities for us to continue to shape this model and increase the number of nurses that we have in the model, and continuously improve in terms of the training and skills and the processes involved in this program.
Yeah, no, and I want to make clear for those watching, we all want 40 hours a week and an RN in every school. Given the pipeline issues that we're seeing across the country and here in DC is just not plausible. So the legislation Councilmember Henderson and I put forward was, given our reality, how we might strengthen this program. Right. Given that, Deputy Director, your testimony noted that 98% of health suites currently have a 40-hour week. That's great news. And I'm eager to see the data that you are going to provide the committee. When we met earlier this year during oversight season, I believe that number was roughly about 90 or so % of schools were roughly meeting 25 to 30 hours a week. What has shifted over the last year that is allowing so many of our schools or health suites to hit that 40-hour a week target?
So we do have more FTEs hired to the program, which allows for a little more consistency, as opposed to having contract staff serving in the schools. And so we've also been able to, I think, increase the number of health techs hired since we last spoke, which has also helped to support staffing at the health suites.
And I know some of the anxiety people have, and it's valid, is this perception that an RN is going to provide better care than a health tech. How are you documenting the health needs of each school, or if there are significant health needs that a student may have at a particular school? How are you documenting that, and how are you tailoring the cluster model so that those schools receive more attention and care from our limited number of RNs that we do have on staff?
So we analyze data from our school health management system, which is the electronic health records system for the participating health suites. And at the beginning of each school year, the health suite staff, as well as the principal of the school and other administrators meet to review the medical forms and other paperwork submitted by parents. And from there, that information is entered into our system. We're able to identify the health needs of students and then incorporate that into our algorithm to determine where it's best to deploy by staff type. Now this—
And so that to me would mean that this is a dynamic cluster model. In other words, that because I'm a registered nurse in this cluster, I may not be there for the entire school year because, let's say, for instance, there's a new student that enrolls at school X that has significant health needs. It sounds like you are ensuring that there's adequate coverage. Is that right? Or is it more static year to year in terms of how you're developing the cluster model?
No, it's ever evolving. You know, a student can develop a new health condition at any point throughout the year, as well as a new student could join the school or a student could change schools. So we monitor this throughout the year and try to make shifts as best we can to ensure that we have the best staff type given the acuity levels of the students.
Understood. Another question there. So I've heard complaints from parents that given frequent call outs from health techs or others, that a registered nurse is often not able to provide care or support because they're filling in for someone else. Can you speak to how you're managing the day-to-day operations given call outs or other emergencies that just may arise, and how or what the expectation is for registered nurses in the cluster model program?
Sure. So that was certainly a significant issue last year. I think we have improved a lot. We're seeing less of that this year, but call outs do happen. As we continue to hire up to our target level, it will have less of an impact when there is a call out. We do, as part of our target, we do include additional staff to kind of serve as a float pool or kind of extra padding to ensure that we have coverage in the event of a call out or extended leave or vacations.
Got it. And then given our almost 100% number of health suites at 40 hours a week, would you suggest the committee, instead of 30 hours a week, mandate that it's 40 hours a week?
I think 30 hours is still a reasonable baseline. As we're doing now, right, we would still aim to achieve 40 hours a week. But it does allow for a little more flexibility in terms of call outs, as well as allows for additional time for professional development and even operational meetings that can support continuous quality improvement.
Understood. That is helpful. And for those watching, the status quo is 20 hours a week. And so this legislation raises that threshold to 30 hours a week. Understanding the challenges the district faces, it also adds guardrails for how schools might request support from DC Health, as well as asking DC Health to provide guidance and more data. So thank you, Deputy Director. I will echo what Councilmember Henderson said. I appreciate your ongoing partnership. And I just want to reiterate that I think everybody that we heard from today, we share a common goal that we want all of our young people in our schools to be well supported but we have very significant challenges, and by working together, I'm confident we're going to meet them. Thank you.
Thank you.
Thank you, Councilmember Parker. Chairman Mendelson.
Thank you very much. Thank you for your testimony. So I'm not feeling very satisfied about this program. I'm going to start with this. So there was some testimony that last year there were about 82 RNs in schools. This year there are 44. There was testimony that the cluster model is causing registered nurses to flee school nursing. So there are two parts to this question. One is why the drop? And second, is there truth that the cluster model is unsatisfactory to these RNs?
As I had mentioned last year, there was a significant amount of contract nurses that were part of the program, and that was contributing to some of the complaints around inconsistency.
Contract nurses would be like temps, temporary.
Correct. So we worked with CSS to ensure that there was more of an effort to hire FTEs to support more consistency and address that problem. So that's why you see a decrease in the overall number, but that was mostly contract nurses. As far as the statement that nurses are fleeing because of the model, I don't know that to be true.
You said you don't believe that to be true. Why?
No. I have not heard that as any reason for someone resigning from the program.
Well, the testimony, which was mostly from Mr. Goulet of the school board, who the school board had a hearing, said that nurses like consistency of working with, getting to know the students, developing a relationship within a school. In the cluster model, they may not be assigned to a school. They may be with several schools, and therefore they don't develop the same relationships, and therefore it's less fulfilling, and therefore they're less likely to stick around.
The nurses that I speak to don't have that sentiment.
Can you provide the committee with a copy of the salary survey that you did on
Sure.
nurses?
Yes.
And that salary survey looks at Prince George's, Montgomery, Fairfax, Arlington?
Yes.
And it looks at LPNs as well as RNs?
I'll need to check. I can't remember if it's
Okay.
RNs and LPNs.
Well, we'll find out when you provide it.
Yes.
All right, thank you. So in your testimony, what the Department of Health would like is that instead of saying that there has to be a registered nurse, an RN, that there would be, I'm going to say, complete flexibility. It could be an RN, it could be an LPN, it could be a health professional certified by the department under the Board of Medicine. I'm not quite sure what profession that means, or certified by the Board of Nursing, or through DC Health's Emergency Medical Services program, or as determined by the Director of Health. So that's like, it could be anybody with some training, but it could be anybody.
Yeah, I think as written, it was very open-ended. And so we're saying that it has
As
to.
written, open-ended? No, the bill says RNs.
I believe it also said, and other health professionals.
It does say for purposes of complying with the RN requirement, it could be a doctor, I think, isn't a person who's graduated from an accredited program for physicians. That would be an MD, wouldn't it?
It's at a physician or a physician
LPN.
assistant or other health professional.
Certified registered nurse practitioner, physician assistant, or a health technician. It seems not as broad as, or as determined by the Director of DC Health.
The term health professional was very broad. And so we're trying to provide a little more specificity around that.
I'm not seeing that. That's what I'm saying. DC Health recommends that health professionals must be licensed, registered, or certified by the department under the Board of Medicine, Board of Nursing, or through DC Health's Emergency Medical Services Program. That says to me like an EMT, or as determined by the Director of DC Health. That's your testimony.
Right, so the bill as proposed said health professionals broadly.
And defined.
So we are saying not any health professional, we are saying health professionals that are either
All right,
certified.
You're talking past me because it defines health professional, which means a physician, an LPN, a certified registered nurse practitioner, physician
Okay.
assistant, or a health technician. And have completed any required postgraduate training.
Right.
But let
okay.
me move on. So I'm going to ask this question. We'll see what the answer is. Do we really need an RN in every school? Or would it be okay if we just had a health tech in every school?
No, the model is not about having a health tech in every school. There are still nurses that are part of the.
I didn't ask you what the model is. I said, do we really need an RN in every school? Put aside the bill, put aside the law.
So
We have how many? We have 117 DCPS schools. We have
185 health suites.
Yeah, but we have more schools than health suites, correct?
Correct.
And
yeah.
how many charter schools do we have? I think it's 160, 165, 117 DCPS schools.
Mhm.
Help me quickly, that's 282 schools. So do we really need an RN in every school?
No, I wouldn't say that we need an RN in every single school. We look at the data to
I'm
determine.
not asking what you're doing, I'm asking what we need. You're representing the health department.
Right.
As a matter of public health, do we need an RN in every school?
We do not need an RN in every school if
Would it
there
be
are other
okay if-
qualified health professionals that can support the RN that are that is part of the program.
Not asking about the program. Would it be okay if we had a health tech in every school? Just simply required a health tech in every school and then you could supplement that. As a matter of public health, as a
Mhm.
representative of the Department of Health,
Mhm.
what do we need in our schools for the public health? Would it be acceptable if we had a health tech in every school?
In every single school without any nursing support?
I didn't say that, just if we had we set a baseline of a health tech in every school.
Right, but that matters. That matters if you're saying there's health techs with no nurses at all as part of the operating structure versus.
Well, maybe, let me put it this way. I think we should take the statute and blow it up because it's not working. It was written in 1987, I think, when it said there would be 16 hours, an RN for 16 hours. I don't quite know why every school has to have an RN as opposed to an LPN. Or maybe someone with health credentials, but maybe not an LPN. I'm inclined to just blow up the whole statute. So starting from scratch,
Mhm.
how about if we said that every school has to have a health tech
Mhm.
and a school over 350 students, I think somebody testified CDC has a guideline, would have an RN or an LPN, or maybe it would be a school with over 350 times 2, 700 students would have an RN. Would that be an acceptable approach from this viewpoint of public health?
Probably not, because there would be more schools where an RN or an LPN would be more appropriate than a health tech.
Why would that be?
And as I was explaining, we look at the data to determine that.
What does that mean?
There are students who may have certain medical conditions or need certain procedures to be done during the school day, which may be more appropriate for an RN to do.
So
or an
in other
LPN to
words,
do.
Department of Health. So we design a new program that's instead of the one we have, and Department of Health is responsible. So then Department of Health would around August 20th, look at the enrollment in the school and say, hey, Johnny's got these more severe health issues, and so therefore we will sign an RN there? Is that the way that would work?
Yes, that's partly how it works.
And where I'm coming from, and I'm over my time, so I'll just end with this, is, although I have other questions, is that I think that the program we have right now, from the viewpoint of parents looking at the government, the program lacks integrity. Parents expect that there is an RN in every school, and there isn't. And then they were promised a cluster model, which would provide RNs, and there isn't. And so what the parents are seeing and what they have been told to expect is very unsatisfying. And I would like to see this legislation fix that. So that was a statement. I will have some more questions.
Okay, thank you. Councilmember Fruman.
Thank you very much, Chairwoman Henderson, and thank you, Deputy Director. I want to start with just understanding some of the numbers. There's a reference to 214 schools and 185 health suites in your testimony. And then the chairman was just talking about 262 schools, but can you tell me what those 214 schools are? That's not all of the DCPS and public charter schools? It's some smaller subset than that.
Yeah, that's the schools that are part of our school health services program.
Okay. And so then 185 health suites, you want to get to a health suite in each of those in each of those schools, or is it not a priority to fill that gap of, I guess?
So we currently have 185 health suites that covers all the DCPS schools. And the majority of public charter schools, there are about 40 charter schools that are not part of our program.
Yeah, but the 214 schools are all part of your program. But maybe there's schools that are co-located, and that's why that every school has a health suite, but there's fewer health suites than the number of schools because of co-location. Is that what's going on?
Yes, there are several schools that may be sharing a facility or on the same campus, and so they might have just one health suite that is shared.
Okay, great. And so then some of the other numbers on the numbers of RNs and LPNs and health techs, I thought there was in your testimony, the goal for each cluster was 2 nurses, whether they be an RN or an LPN, and 2 health techs, which would make me think that the total number of nurses and the total number of health techs would be similar. But the numbers are 76 nurses, LPNs, and RNs, and 122 health techs. And then your goal looks like 101 nurses and 143 health techs. So is that the 2 and 2? Is that part of the model, or is that the goal, or how does that work given the difference in the number of total nurses and the total number of health techs?
Right. So we have 47 clusters, but as I was mentioning, our target number for hiring also exceeds what would cover each individual school to allow for extra coverage in the event of call outs or vacations or extended leave.
I see. So
or
the
resignations.
Yeah. So the goal is 47 RNs, 1 for each cluster, 54 LPNs. That gives you a cushion of 7, but.
And then we also have 8 nurse managers.
I see. Okay. And how are the clusters formed? Is it geography? Is there anything, do you have the ability to have where you might have a DCPS school next door? to a charter school, that a DCPS and a charter school would be in the same cluster? How do you figure out what the clusters are?
Yes, it is primarily geographically mapped to ensure that the schools are within close enough proximity to each other for the nurses to be able to support that cluster.
And does it cross LEA lines? Can you have a DC, a cluster of 4 schools and 2 of them are DCPS and 2 of them are charter schools?
Yes.
Okay. And then what kinds of mechanisms are in place for the professionals in the cluster to be in immediate communication? Do they call each other on cell phones? Is there something that's linking them? How are they linked so that it's an actual cluster as opposed to 4 people operating separately?
Yeah, so they have the phone systems as well as the telehealth equipment to communicate with one another.
So in the telehealth equipment, that's all linked together amongst the health professionals in the different schools in the cluster?
Yeah, so they can actually see or observe what's happening in a health suite via video.
And then I hear you on, the challenge of assigning people. I had a school in particular last year where there was a student who had a particularly high need and there wasn't an RN there, and you really wanted an RN there. And I think eventually we got there, but it took a bit. I think when the chairman was asking you, could we just have health techs? I think that there are places where there are students who have very high needs and you actually want a nurse there or would need to have a nurse there. And maybe other schools where a health tech usually could be enough, but you would want them to have support from an RN or an LPN. But how does anybody lose the lottery? So your goal, I guess your goal is to get to a place where there's 101 RN in each cluster and 1 LPN in each
101 nurses, so that's RNs and LPNs, yeah.
But and maybe some of that would be, but are there more than 101 schools where there's a need for a nurse, because you hate to have, and this is where I think what the chairman's question comes up is, in the last year, the school that I'm thinking of lost the lottery and it didn't have a nurse, but I think lots of people thought, well, we wish we had a nurse. And if we had nurses in 101 schools, do you think that we would be covering all of those places where there's a kind of acknowledged acute need to have a nurse there on the front lines?
So the health techs have to be in a model that includes nursing as well, right? So that's why I was trying to clarify the question. If we're saying that, do we support a model where it's only health techs in the health suites and there's no nursing component to it? No, we would not promote that. But there are schools that we have right now that, let's say, don't have a significant number of students with conditions that a health tech could not handle. And so if that health tech was not there, the alternative would be phone coverage by a nurse. I think we could all agree that it is better to have a health professional in person than to just have telephone coverage.
Oh, no, I hear you. And I think, everybody, this is calling for a health professional there 30 hours a week. And the fact that you're at 40 hours a week, I would want to try to get it to be 40 hours a week, because the last question I'm going to ask about has implications for that. But it's not that, it's that when you assign you look at, okay, which schools get an RN and which schools get an LPN and which schools get a health tech. You do that in part by assessing what the needs are at the schools.
Correct.
And you assign the nurses to the schools with the highest needs. And what I'm concerned about is once you're done with your nurses and LPNs being assigned to schools with the highest needs, what does that 102nd, 103rd, 104th, 105th school look like? Are we having nurses in the model that you're aspiring to? Will we have nurses in place in every place where there are a significant number or kids with significant needs that you would have wanted to assign a nurse to that school?
Yes, so we would, in the model, the goal is to have one RN stationed at a health suite in every cluster. And then there may be additional LPNs at other schools in that cluster, depending on the needs of that school. In the event that we do not have enough nurses to, let's say, be staffed at a school where we see a need, there is effort put into attempting to hire those nurses and shift.
So I hear you. I think we're missing each other a little, but I think maybe you just got at it, that if you got to a place, and I'm over my time, but if you got to a place where you had your 101 nurses, but you had a school where there was objectively a strong case why there ought to be a nurse there, then you would expand the number of nurses that you sought in order to meet that need, as opposed to just leaving it with a health tech who could be very, very qualified, but your goal was a nurse in a setting like that, supported by a nurse, that where there was a very high need school, you would try to meet that need with a nurse.
Correct.
Fair?
I can say that the targets we had a couple months ago were different from the targets we have now based on those meetings that occur at the beginning of the school year and the data that we monitor.
And
thank you,
I gotta go.
Councilman.
I'm done for now. Thank you.
Thank you, Councilmember Furman. We'll do another round of 7 minutes. Do you need more than 7? Okay, we're gonna start with 7. If you need some additional time, Mr. Chairman, we'll accommodate as much as we can. All right, a couple of things. I believe DC Health has already established a deadline for LEAs to notify the agency about needing school health suite staffing for the following year. Is that correct?
Yes, I think for the transition year, the cutoff was in June.
Okay.
But we are comfortable with the October 31st moving forward.
Okay. And so I guess October 31st is this year, the first year we will start to enforce for the following school year.
Correct.
All right, so that's our PSA to all of the people who are thinking about, I don't know, starting a school. You have 25-ish days to let DC Health know. One challenge not addressed by this bill is the absence of health suites from some schools. We had some testimony from some charter LEAs who said, we don't have enough physical space in order for us to be able to have a health suite. As the public health agency, how comfortable are you all with schools not having either a health suite or someone there in general?
We're comfortable with, let's say, the requirements that are going to have to be met for our school health services program to be reduced for charter schools who are not currently in the program, but who would be required to hire staffing under this legislation.
Yep.
We just also want to make sure that some basic standards are met and there's some level of oversight for that.
So on that front, I'm not sure if you're aware. So in the behavioral health space with the school-based mental health program, we had this pilot for the last 2 school years where after several years of doing the school-based mental health program, we had high vacancies. We are allowing, I think there's like 15 charter LEAs that they've been granted the funding to be able to hire someone on their own. And there was quite a bit of testimony from some charter LEAs today who suggested maybe we should match that in this program. What are your thoughts on that?
I mean, we're aware of 27 charter schools that do hire their own staff right now. So that's 27 out of the 40.
I know, but this is the difference is that they want the money. They don't want to just be able to hire their own person.
Yeah.
They want you guys to pay for it essentially, not you guys.
Right, but we would need money to give, yeah. I am aware of some of the challenges in hiring those staff, even though the money was provided in that behavioral health space. I don't know if we would still have that challenge here. But if there was money available and enough charter schools are committed to that, I don't see that as a problem.
Okay, so let me just say, it's not additional money. We didn't do additional money for school-based mental health. We essentially took a portion of the money that was already granted for that program and set it aside for this specific purpose. So when they're talking about matching it, that would be the same. Taking the amount of money that we set aside for school-based health services to reduce it by, I don't know, however many $100,000 in order to be able to do this. And then they essentially are able to hire their own person, obviously up to the standards of what you all would require.
I mean, that would pose a challenge then to the schools who are in the school health services program.
If continuing in the cluster posture, yes.
Right.
Okay. The bill requires DC Health to provide some technical assistance to schools that are not participating in the school health services program. Do you think that the bill should be more specific in terms of what type of guidance is part of the technical assistance piece?
I think that we could develop some rules around that, or that we can develop a plan for that. I'm not sure if that really needs to be legislated.
Okay. In terms of going forward, so our school health, well, this year, we kept some money within DC Health in order for you all to hire more folks for this particular program. And I'm just trying to sort of forecast on where we're going because this is a grant. Is DC Health considering either recompeting? I think we do a sole source. So is there any conversations about recompeting or perhaps looking at a different model?
So the grant was competitive.
Okay.
And this year, as we are transitioning,
Wait, I'm sorry, the grant was competitive?
Yes.
How many people applied?
I believe it was 2.
Oh, okay.
Yeah. So the grant was competitive. This particular school year, we did a continuation or an extension just to make sure we could continue the program during this transition year. We will soon be releasing an RFP.
Okay.
And we are still considering, perhaps other components of the program that we want to have in place or, in-house.
How much more expensive would it be if we did what PG and some of the other jurisdictions did, which is essentially hire nurses as though they are DC government employees?
I mean, I think the estimates you shared earlier were pretty accurate, somewhere
30.
between 31, 35 million.
Okay. You testified about the challenge of implementing the bill for adult charter schools, and you suggested exempting them. We had someone who testified earlier from Berea. Their relationship is always very unique because they are many of their locations are co-located with a health center.
Right.
You were speaking specifically to adult charter schools. Would this also apply to the state programs within DCPAS as well? Because I often hear from, what is it, Garnett, Patterson,
Right.
Stay, Old Roosevelt Stay. They wanted a nurse. And
Yeah.
so,
Yeah, I think part of the challenge with them in previous years was the staffing level, and trying to make sure that the K through, 12 schools for youth came first, since adults, are able to manage their own healthcare. They can administer their own medication. If they need emergency care, they can handle that themselves, or it could be handled like it would in any other workplace, right? If an adult was to get sick at work, essentially.
all right, I'm over my time. Mr. Chairman?
Thank you. You said a few minutes ago, health techs have to be in a model with an RN. Why?
The health techs are supervised by an RN. So RN can delegate duties to
Is that
an
medically-
unlicensed.
Not medically necessary or professionally necessary?
Yes.
Or is that just simply the model?
No, it's required by law. The unlicensed health professionals are able to be delegated duties by an RN.
And how many health techs, how many different schools could one RN supervise?
So we have the
I'm
8.
not asking what you have, how many could, but what does the law allow?
The law doesn't say anything about the number.
So an RN, does it have to be an RN or could it be an LPN?
An RN.
So an RN could,
LPNs currently by law are allowed to assign tasks, but those tasks have to be within the scope of that unlicensed professional. An
And-
RN can delegate duties that are under the scope of an RN.
and how many health techs could a RN supervise?
Right now,
10, 20?
right now we have about 4.
I'm sorry, for an RN can supervise
Right,
4.
so if we have an RN in each cluster, and then we also have
forget
an
the cluster.
RN in each ward that is the nurse
Could an
manager.
RN
They have
supervise,
oversight over all of those health techs.
can an RN supervise 10 health techs?
Good.
You like the deadline of October 31st, which was discussed earlier. That's 10 months from the start of the school year. Why does it have to be so long? And you testified that right now the requirement is June, which would be like 3 months.
I'm sorry, I missed that. Repeat that for me.
You like the requirement of a deadline of October 31st. This was discussed earlier. However, you also testified that right now the practice is June, which is about 3 months. Why do you need 10 months?
No, so last year we instituted a cutoff in June as we were in transition. October 31st is preferable because then it allows us to know how many schools will be in the pipeline during the time that we're doing program planning as well as budget preparation.
Is there that much change from year to year with regard to the number of schools?
I mean, any school makes a difference in terms of the budget. And if there are schools that request to be in the program after we already have our budget set, that can pose a problem.
And when is your budget set? I'm
Say-
sorry, you not hearing me?
Yeah, no, I'm sorry, I'm not hearing too well.
When is your budget set?
Our budget is usually set prior to the fiscal year.
Oh, like when the council adopts it in June?
But we need time
Okay,
to
and when the
plan.
schools
We can't wait till June to plan.
You testified that approximately 98% of health suites in the program currently have a 40-hour week, in-person staff member assigned. There was testimony from one of the parents. They did a survey. It wasn't very broad. When we asked parents and students and parents to check to see if there was a staff member in their health suite, we received 17 responses from 16 schools. The survey showed that over 30% of health suites were not covered on the day in question. Can you explain that
I'm very interested in following up with that parent to get more information.
So then you will follow up?
Yes, I do plan to
And you've
follow
heard
up.
her testimony, so you know who it is.
Yes. I've already asked my team to follow.
So I have concerns as well about these health suites. So there was testimony, I'm reading health suite approval process is complex and can take up to 2 years to complete. These issues coupled with a 13-page checklist of health suite requirements have made it prohibitive for many schools, including our smallest schools, to complete the process. In follow-up questions, it was commented that once that the inspections from Department of Health are iterative, meaning that Department of Health inspector will change what the requirements are. An example was given regarding a specific brand of cot or as the length of a counter. I looked at the checklist. The checklist requires a counter. It doesn't specify a length. And if I remember correctly, it identified a cot, but did not identify a brand. Can you explain why this is happening?
Yeah, I did hear that testimony and I plan to follow up on that. I don't have information about
So you
it.
don't know, but are you aware that the process can take up to 2 years to complete?
I think the issue that occurred previously is that health suites that were in the process may have been delayed in terms of approval while waiting for confirmation of staffing. I think that, so that is another reason why having the cutoff date really helps in terms of planning and will allow schools to have more clear expectations about when they would receive
So a
staffing.
health suite is not just simply a physical attribute, it is physical as well as personnel.
Right, so you.
So isn't
you
this like
might
catch
have an
22?
Say it again.
Isn't this like catch 22? So let's take a school building. They build a health suite. They meet
Right.
all your requirements.
Mhm.
It doesn't count unless they have a staff person. So
No,
you
no,
won't
no,
say
no,
that
no,
they have a
no.
staff health suite
No,
unless
no.
they get a person.
No, let me clarify. No. I think in the past, if there was a school that met all the requirements to have an approved health suite, but there was no staffing available, I think there was a delay in that school being informed that they were approved.
Well, that's not the, so you'll delay the approval of a new health suite until there's a person,
I think that's what happened in the past.
but not the current practice.
Correct. And having the cutoff
So I
helps to
want to
prevent
understand
those-
as a layperson,
Okay.
how it is advantageous that, from the standpoint of public health, that if a school, let's take Wildflower, is so small that it can't meet all the requirements of a health suite,
Mhm.
we therefore just exclude it from the program. So it has nothing. So it's kind of like all or nothing. I'm not quite getting how that's in the best interest of public health.
This would allow them to actually hire their own staff as well as receive technical assistance from us.
What's the this?
The proposed bill.
The bill.
Yeah.
So you see the bill as actually an improvement upon the current situation with regard to a school, small school such as Wildflower.
I think if we are going to have a school and be responsible for the students, there has to be a way to provide some type of healthcare to them. And if they are going to be a part of our program, they would need to meet certain requirements. If they're not going to be a part of their program, they could still hire their own medical staff, or we could help them with some other type of option.
I have no more questions. Thank you very much.
Thank you. Councilmember Furman?
Thank you very much. I have a couple of questions. I hope I don't use the full 7 minutes, but we'll see. I'm still trying to understand some of the numbers, and on the goal of 47 RNs, there'd just be 1 RN for every cluster, but there's did you say there's 8 supervising nurses, and are they RNs?
Yes, there are 8 nurse managers who are RNs. And then with the funding that we at DC Health are receiving this year, we will also be hiring 8 contract RNs with the 1-year funding.
So does that mean that it's 63 RNs, that those are not part of the 47, or are they part of the 47?
They're not part of the 47, no.
Okay. And so then, and that I worried a little, because if there's 47 RNs and 47 clusters, an RN is gone, there isn't enough an RN to cover that. Another RN would have to would cover 2 clusters, but maybe there's a nurse manager who steps in.
Yes, nurse managers do step in as needed. And we also expect that our staff will be able to support with additional monitoring and compliance on the ground. And if needed, can also support the health suite.
So then that makes me think, if there's 1 RN per cluster and there's an LPN and there's 2 health techs, that RN is supervising 3 people, 2 health techs and 1 LPN. Is that not the typical case?
The LPN doesn't have the same requirement as a health tech in order to have that direct supervision.
So, but it's no more than, it may be that the RN could be providing advice to the LPN, they're part of a team.
Yeah, yes.
Okay, so then.
And general management by the nurse manager.
Right.
Yeah.
So it's most typically 2 health techs that an RN would be supervising, it seems to me. I still am concerned about the situation. You have an algorithm where you try to figure out what are the highest priority schools where you would want to put an RN and where you'd want to put an LPN. And I'm worried about when you've used up all of your RNs and your LPNs, what are those schools that don't quite make the cut look like? In order to feel comfortable that we actually have RNs and LPNs in the places where the needs are the highest, is there a way for you to share the output of that algorithm, even if it kept the schools? There's privacy issues, but just to see what does it look like for the schools that are, in terms of your own analysis of needs, what are the ones that are not getting an RN or an LPN look like in terms of the needs on the ground? Could you share that?
We can see what we can share.
Okay. I would be very curious to see that.
Yeah. And again, the alternative would be telephone coverage.
Actually, I'm interested about that because there is the reference to the telehealth and I'm curious, is the telehealth, what's the trend line in the use of telehealth? Is it being used more in recent years, or is it stable?
So telephone coverage is not the same as the telehealth program. Telephone coverage means the school can contact one of the nurse managers for support, but there's no one on site.
No, I know, but there are schools where you think it's important that there be a nurse on site, and that's what I'm trying to figure out, is where that line is. But in terms of the telehealth program that you reference, is that a growing phenomenon, or what's that look like?
Yeah, we started the pilot a few years ago. Last year we had close to 600 visits. Those are mostly asthma related, other types of, let's say, minor conditions like ear pain or things like that, that a provider can, quickly monitor and then make sure the child has medicine And then a parent doesn't have to, take off extra time from work to take the child to an extra appointment.
And who's on the other end of that telehealth? Is that an RN, an LPN, a health check?
The health suite. Oh, on the telehealth, it's a physician.
Oh, it's a physician. Okay.
Mm-hmm.
You talked about last year there were a lot of contract employees and you're trying to get that down to be FTEs. What does it look like this year? Of all the people that you listed, are they all FTEs at this point, or how many of them are?
Yes, they're all FTEs.
Okay, and that I'm going to be very curious to see how the salaries, the pay compares, because this is a tough world in nursing. The demand for nurses is high, and if you're going to meet your goals, so I'll be very curious to see the regional, our regional competitiveness. Last thing, one of the things people talk about is after school, and I'm curious how you see your program and your role vis-a-vis the after school needs.
So, beyond this program, I oversee the entire community health administration. And so we have been working with DCPS on a plan to offer additional AOM training to staff beyond the minimum requirement, as well as staff in their after-school programs. So we have a tiered approach to be able to train a new cadre of staff by December of this year. And then by the spring, DC Health will be taking over the AOM training from Children's School Services. And, as part of emergency medications program and other things, we will have more opportunities to provide training to school staff.
Well, I really appreciate that, and we finished, and I didn't use my whole 7 minutes, so thank you.
Thank you.
Thank you, Councilmember Freeman, and thank you, Chairman Mendelson. I have just 2 remaining questions. One, we heard some testimony from some of the public witnesses around coverage in the after-school hours, particularly with sporting events and those kinds of things. This is not the first time we've heard this, and I'm curious what conversations DC Health is having around what guidance or like baseline should exist, especially as we're seeing more sporting events going down to the elementary grade level.
Right. So I know we've been having some conversations about this internally as well, and the need for athletic trainers to be included as part of the requirement when it comes to organized sports.
Yes.
Yeah. So that is something that we definitely support.
Okay. And then the last question would be just sort of around enforcement. Let's say we were to move forward with this particular legislation and we had charter LEAs or even some DCPS schools who chose not to comply. What would happen?
We would be partnering with our state education office, OSSI, and working with them on the follow-up with schools and kind of the monitoring and compliance on that front.
Okay. All right. I don't have any other further questions. We do have a couple of follow-ups, so hopefully the team was able to take those down, and obviously we will send a follow-up on that. But this concludes today's hearing. I want to thank all the witnesses who spoke today. As I said before, the record for both Bill 25-948, the Certificate of Need Improvement Amendment Act of 2024, and Bill 25-0690, the Public School Health Services Amendment Act of 2024, will remain open until 5 p.m. on October 23rd for public to submit testimony. You may submit written testimony statements via the council's hearing management system on the council website at dccouncil.gov/hearings. The committee will hold its next hearing on Thursday, October 17th at 9:30 a.m., where we will consider 2 nominations to the Board of Respiratory Care and 1 bill, Bill 25-930, the Consumer Health Information Privacy Protection Act of 2024, also known as CHIPA. There being no further business before the committee at this time, it is 2:23 and this hearing is adjourned. Thank you.
Thank you.